is organized by Digital Europe and Croatian Chamber of Economy under the patronage of the Croatian presidency. I would like to thank Croatian Ministry of Health, Ministry of Administration, and Central State Office for the development of digital society, for the support they have given us in organizing this event. Following the European Commission's announcement of the digital strategy and in expectation of Council conclusions, this event will share the EU's best practices and navigate a dialogue towards future digital policies and initiatives with regards to artificial intelligence, mHealth apps, telehealth, and a common European health data space. This event will also have a particular focus on vulnerable communities to the virus, in this case, people living with cancer. What was done to ensure those suffering from life-threatening diseases are not sidelined during a crisis. But first, at the very beginning, let's have a few house rules. To our audience, I would like to remind you to keep your microphones and your cameras off at all times. This will help improve the quality of the sound. Also, if you right-click on your name, please ensure your name and organization is visible. Thank you very much. Today, you will hear from policymakers and leading experts in the field, and you're invited to take part by asking questions in Q&A section on the right side of your screen. To make sure we get the chance to take and answer a couple of questions, I will kindly ask our speakers today to stick to their time slots as they were agreed upon. If not, I'm going to be very rude to some of you. Now let's start with the summit. We have 4 keynote speakers, and they are Ray Pinto, Digital Transformation Policy Director, Digital Europe, a trade association representing 40 national trade associations covering digital policy. Tomislav Radoš, Vice President, Croatian Chamber of Economy. Joanna Maria Gligor, Head of Unit, DG Sante, European Commission responsible for the important programs to facilitate the cross-border flow of health data. And last but not least, Bernard Gršić, State Secretary of the Central State Office for the Development of a Digital Society. Mr. Pinto, can you hear me?
I sure can, Antonia. Thank you very much. Good morning.
Oh, good morning to you too, sir. So I know that you're going to open this lovely event with a couple of words, so please take it away.
Excellent. Thank you very much. If we could just go back to the previous slide. Perfect. Okay. So good morning, everybody. Thank you for joining us. Antonia, great to see that you're in an office. I look forward to that one day. Calling in from my home here in France, in Chantilly. I'm stepping in for our Director General of Digital Europe, Cecilia, who cannot join us today, so she definitely sends her apologies. Today is about something that did not get talked about a lot or enough of during the COVID crisis, and that is about the vulnerable communities that were suffering or are suffering from diseases. In this case, we're going to be focusing on cancer. And the question that we're going to be looking at in a panel that I will moderate later on is, how do we make sure that they can get continual care? And for that to happen, as we have seen with COVID, we were all challenged by having access or utilizing the digital and technology tools. For most cases, it worked well, from talk show hosts to presidents to business people to everyone around the world, and even now we're using these conference tools. But we still have a lot of work to do. There is still connectivity issues. There's very low broadband and bandwidth. There's remote areas that do not have access. There's people that don't have the skills to use it and who are vulnerable. And very importantly, what you'll hear a lot today, it is a question of data. Access to data powers the digital tools. It powers the devices. It powers AI. It improves and innovates the solutions to provide treatment. And it powers the Internet of Things. And all these different elements will ensure that people who have life-threatening conditions can be treated. And here's some stats that we have on the screen. health systems are producing 30% of the world's stored data. And unfortunately, we still do not have our health records that are digital, and we can't get our health records going over EU borders. This is an issue. And as you can see, a lot of data remains untapped, and there's still a lack of skills. If you go to that next slide, please. Great, thank you. At Digital Europe, we are in constant discussions with officials, with stakeholders. Some very important ones are here today, so I welcome all of them from the Croatian government. I also welcome the European Commission. I welcome the European Cancer Coalition, who will be here later on in our panel. But what we're looking at is how can we make sure that we can get some guidance. We can make sure that data protection rules are harmonized across the member states, which is still an issue even in this period of GDPR. The Commission is doing a lot of great things up ahead. We're excited about it. The European health data space, a code of conduct that can provide assurances where the private sector can work with the public sector in research, create central data authorities so that we can reuse the data for research. And there are standards that will solve cross-border interoperability. This one that's highlighted is FHIR. It should be used and adapted very broadly. So we see a lot of great things. We've seen now the budget proposal for the EU for health, which has a big budget, and it should be ring fencing a lot of that money for digital usage. I'm going to stop there, and you'll hear back from me at the panel. I hope you can stay tuned and join us in just a little bit.
Thank you so much, Ray. That was awesome. As you said, we're going to see you and we're going to hear from you later on, as you can see. I got company. Please welcome Mr. Tomislav Radoš, Vice President of Croatian Chamber of Economy. He's going to say a quick welcome as well. So welcome.
Thank you. So good morning, ladies and gentlemen. So it's my special honor and pleasure to welcome you on behalf of Croatian Chamber of Economy as the co-organizer of this virtual event, and I would like to thank our partner, Digital Europe, for all support. I would like to emphasize that the Croatian Chamber of Economy is the first institution in Croatia that is fully digital transformed with the use of our digital chamber. I am glad that this conference is taking place under the patronage of the government of the Republic of Croatia, which is presiding over the EU for a few more days. In today's information-intensive economy, information and communication technology, ICT, plays a pivotal role not only in enabling firms to achieve operation excellence, but also in facilitating strategic competitive advantage. The progressive digitalization of all industries, from fast-moving consumer goods to the insurance sectors, from aerospace to traditional manufacturing firms, from fashion to apparel, to interfreight transportation, provides consistent opportunities to disrupt the way value is created, transferred, and defended against competitors. The healthcare industry is not an exception to this trend of ICT utilization. The digitalization of healthcare assets is widely considered one of the most effective answers to the growing pressure of augmenting the quality of healthcare ecosystem while simultaneously reducing their costs. In fact, ICT offers opportunities to consolidate the capability to exploit current assets with the capability to shift away from them in order to explore new and better ways of delivering value. This year, 2020, should have been the start of an exciting decade in medicine and science, with the development and maturation of several digital technologies that can be applied to tackle major clinical problems and diseases. These digital technologies include the Internet of Things with the next generation telecommunication networks 5G, big data analytics, artificial intelligence, and that uses deep learning and blockchain technology. But in 2020, the world is facing an essential global healthcare crisis, the outbreak of COVID-19. Although the focus of tackling the direct impact of COVID-19 is important, in many healthcare settings, it is important to maintain core and critical clinical service. The initial reaction in many countries is for healthcare facilities to reduce or even cease many clinical services, including closure of clinics and postponement of medical appointments or elective surgeries. However, such strategies cannot be sustained indefinitely if the COVID-19 pandemic extends beyond 6 months. Healthcare systems should plan to use digital technology. Virtual clinics could be set up through the use of telemedicine consultation with imaging data uploaded from peripheral sites and interpreted remotely. This would ensure that patients continue to receive standard clinical care while reducing physical crowding of patients into hospital premises. For other key hospital activities, virtual learning platforms are increasingly being explored to eliminate physical meetings. An online medical chatbot such as Andrea here in Croatia help patients recognize early symptoms, educate people on the importance of hand hygiene, and refer people for medical treatment should symptoms worsen. The immediate use and successful application of digital technology to tackle a major global public health challenge in 2020 will probably increase the public and governmental acceptance of such technologies for other areas of healthcare, including chronic diseases, in the future. As the saying goes, a crisis provides an opportunity. The first great crisis in 2020 provides a great opportunity for digital technology. Healthcare is the area where digitalization can produce the most significant and noticeable impact. We are definitely on the way to smart hospitals where robots work together with doctors, and to the population where people monitor their health via smart devices and software solutions. It is important to emphasize that this time of COVID-19 has significantly accelerated the digital transformation in all segments of public administration, industry, health, and is present in all spheres of our lives. Policymakers should now realize that investing in digital is precondition to achieve the program's priority of making Europe's health system more resilient. And finally, I wish everyone a successful event, and the conclusion that emerge from it will guide policymakers both at European Union level and at the national level. Thank you.
Thank you very much, Mr. Radoš. And now we go to Mrs. Gligor next. Johanna Maria, can you hear us and see us?
Yes, I can.
Good morning.
Good morning.
It's so good to see you. I mean, I did. Oh, yeah, I can see you.
Do you see me now? Thank you very much. Thank you very much for the invitation. And it's really great to hear the discussions today here. If you can project the first slide, please. Next one. We were discussing, Ray was speaking about the European health data space and the fact that the Commission is working on setting up the European health data space. As you know, the Commissioner Kyriakides, she has in her mission letter as a mandate the setting up of the European health data space, which would promote health data exchanging and would support the research on new preventive strategies, treatments, medicine, medical devices, with allowing the citizens to have the control over their own health data. Next slide, please. Now, what is the aim of the European health data space? For the Commission, the aim is to ensure that the data is used for better healthcare, better policy making, and better research. And this basically would be structured, the action on the Commission side would be structured along 4 main pillars, aiming at setting up the right governance structure for the use of data at national level, but also at the European level. Having removing basically the barriers to the free movement of digital services, and also ensuring a framework for the artificial intelligence and for the liability in this area, especially in the healthcare. The second area of work is related to the uptake and the development of the electronic health record exchange format. This is quite an important work, which basically it's absolutely fundamental for this area. We have started with the electronic health record exchange format with the communication, and the member states are working, but still much has to be done. Another area of work is the verification, the so-called verification of data, which means basically making data findable, accessible, interoperable, and reusable. And there are a lot of sources of data which can basically be quite complicated for the researchers to access. Another area of work which is very important and where work has already started is the infrastructure, not only for exchanging the patient summary and prescriptions, and I'm very happy to say that Croatia is among the countries which are exchanging this kind of information with other member states, but also discussing the cases of rare disease patients, discussing also cases with of patients with rare cancers, through an IT tool which puts together over 300 hospitals in Europe, basically allowing for access to the genomes, 1 million genomes by 2022. Access of the regulators to data, linking different repositories, including cancer repositories, and supporting the development of artificial intelligence also for cancer with the images database for developing AI tools for cancer, but also linking the data permit authorities when in the countries that set up, and supporting the member states to set up institutions which allow for the secondary use of data, basically using the data which are collected for healthcare, but using them for policy making and for the research. And last but not least, a very important area of work is the digitalization of healthcare systems. Here, basically, the work is ongoing. It has started already with the support from the national funds, with support from the European Regional Development Funds and ESF. But the EU for Health, we hope that we will bring an important contribution to this area. There is also a lot of work going on for telehealth and artificial intelligence, improving the digital skills, not only in terms of funding, but also in terms of supporting the member states to develop the right strategies and to put the right actions in place. If we go to the next slide. Thank you very much. So I was mentioning already different types of digital tools which have been developed through the crisis. I think they are a very positive development. We have been using this quite substantially for the rare disease patients. But I think there are still obstacles, especially for the provision of these services between countries. For telemedicine, a lot of member states have adopted laws. They have changed their laws in order to allow for the provision of this telemedicine, telemonitoring within countries. However, the provision between countries is much more reduced. You have also on this slide a nice diagram. I mean, I like it a lot because basically it shows how the exchange of patient summary and prescription is done between different member states. And I think it allows for keeping the specificities and the legislation in the member states by using national contact points and allowing basically the exchange of this information between countries. And I'm very happy that Croatia is part of these exchanges. Now, the new game changer, I think, is the EU for Health program, which has an important budget in the proposal of the Commission of 9.4 billion, and we hope that an important part will be dedicated to the digital transformation of health and care. The co-legislators are now discussing this. You can see that the digital transformation of health and care is one of the areas of work. In the next slide, you will have a little bit more details about the different areas which are being financed, from IT infrastructure, IT tools in the member states, cross-border, which is extremely important, trying to link together the different member states. So we hope that basically we will see how the work how the EU for Health will look in the end, but we hope that this will support this digital transformation together with other funds, with the Digital Euro program, with the European Regional Fund at national level, with European Social Fund, with InvestEU, etc. And this is a moment where the next MFF is being built up, and I hope that the member states will take all the measures in order to use at the maximum these funds, and we hope that we can support them to put the right structure in place, to build interoperable infrastructures, to build interoperable electronic health records, and at the national level. And we are working very strongly with also with the eHealth network in this regard. What are the next steps? Thank you very much. We are having an important discussion in the EBSCO Council on the digital and the European health data space, and we hope that we'll also have council conclusions later on in the presidency. There is a joint action which brings together different member states in order to build a European health data space. So it's toward European health data space. It's quite an interesting acronym, but I think this shows the spirit in the member states, which are really putting a lot of efforts into developing this and making sure that the data is used for research and for the policy making, in addition to the use of data for health, which is much more advanced. Thanks to the eHealth network, the work has advanced much more there. We are also planning to launch a code of conduct, to support actually a code of conduct for the organizations on the ground to develop such a code of conduct, which of course has to be built by them. We are also we have started basically together with the German presidency a series of workshops concerning the need for action, and what it comes out of those workshops is a big attempt from the stakeholders to develop the code of conduct, but also to come up with legislation which would allow for setting up the European health data space and would basically eliminate or reduce the fragmentation which currently exists in this area. And last but not least, building the infrastructure, EU for Health, but also in complementarity with the other programs, and I mentioned them earlier, European Regional Development Fund, the Digital Europe, European Social Fund, InvestEU, etc. So thank you very much. I hope I kept the time, and I look really forward to this discussion and to any questions from the audience. Thank you.
When it comes to the duration of your presentation, well done. Well done. Perfect. Duration was perfect. Thank you so much. Okay, and thank you very much, Mrs. Gligor. And our last keynote speaker for today, Mr. Bernard Gršić, State Secretary of the Central State Office for Development of Digital Society. Mr. Gršić, can you hear me?
Yes, yes. Hi, Antonio.
Each week we have one conference that we share together. We're going to become best friends.
Yeah.
Take it away.
Thank you. Ladies and gentlemen, I greet you all warmly and welcome to the high-level Virtual Policy Summit post-COVID-19, Europe's Digital Health Future, from Sharing to Empowering. The COVID-19 pandemic proved to be an accelerator in the application of digital solutions, both in the private and public sectors. Therefore, it is not nutritious to say that in one way of epidemic forced us to make a big, not only mental, but also a virtually applicable jump when speaking of the use of various digital solutions. Digital technologies are used in many sectors, such as health, agriculture, transport, education, retail trade, automation, energy, shipping, logistics, teaching, and information and communication technology industry. Demand for information and communication technology experts is growing. In the future, 9 out of 10 jobs will require digital skills. In the European Union, 40% of firms have problem finding ICT specialists. This could mean 500,000 unfilled positions in the ICT sector by the end of this year. Employees will have to be able to work with sophisticated machines and its solutions as part of their daily activities, from auto mechanics to doctors and nurses. Digital business is vital for innovation, growth, jobs, and European competitiveness. The proliferation of digital content has a huge impact on the labor market and the type of skills needed in the economy and society. This changes the structure of employment, leading to the automation of the routine task and creation of new and different types of jobs. It leads to the need for more qualified ICT professionals in all sectors of the economy. It leads to the need for digital skills for almost all jobs. It changes the way we learn by encouraging networks, enabling personalized learning experience, and supporting the development of soft skills such as problem solving, cooperation and creativity, and making learning fun. It leads to the need for every citizen to have at least basic digital skills to live, work, learn, and participate in a modern society. The future of work is one of the key challenges of our time. How we manage this challenge will define the future of our continent. Digital technology, for example, can help us become the world's first climate neutral continent by 2050. Smart power grids can help facilitate the transition to renewable energy, allowing us to adjust the electricity we use to what we produce, not the other way around. Agricultural machinery can use artificial intelligence to reduce the use of pesticides, so farmers can produce more with less impact on the environment. Therefore, as you know, investing in digital technology is a key part of the European Green Agreement. Digital transformation is not just a European challenge, it represents a global challenge. Digital transformation does not only refer to the future of work. This is about the future of the economy, society, and the democracy in a global framework. The future of work depends primarily on digital transformation. We cannot and must not stop these changes. Our digital values and knowledge are our most valuable capital, which give us a competitive advantage. As you certainly know, the European Commission has taken steps that include investments in ethical, human, artificial intelligence, protecting and privacy of our citizens, protecting of European democracy from hacking and fake news. Furthermore, the European Union recognized the importance of digitalization, provided part of the budget for the Digital Europe program. Therefore, much is at stake. Primarily, the digital future of our European social market economy, based on the idea that economic growth and social progress are going synergistic. What we need most in the digital age are digital skills, and that is why the first principle of the pillar of social rights is education, training, and lifelong learning. Some businesses and work process will disappear as a result of inevitable and omnipresent digitalization. Jobs that rely on routine can be easily automated. So today we can already see robotic journalists, machine translators, and investment bankers based on artificial intelligence. I see that many of you are beginning to worry, but you should not be afraid. Some jobs will disappear, however, many new jobs will emerge. Most of all, business and methodology of business processes will change. So it is extremely important to continue learning, adapting the entire working life, even after it. Many of you are also parents and grandparents, and you might just be wondering how my child thrive and survive in the digital age. What if they are not good of match for ICT? I tell these parents that it is not all about digital skills. In the period of digitalization, we must not forget creativity and humanity. Innovation do not exist without them. We should all try, not only teach children programming, but also how to be critical and creative. Not only teach children how to use technology, but also teach them what teamwork is. Not only teach children how to build computers, but to teach each other how to build mutual trust. Thank you for your attention.
Thank you very much, Mr. Gršić. So lovely to have you on this conference. Thanks again. We do have a couple of questions. What I want to check is Joanna Maria still with us? If you are, please.
Yes, I'm still with you. Yes.
You are. Okay, I have one very interesting question that relates to what you were saying at the beginning. You can turn the video on as well. Turn the camera on.
Okay.
So the question is about contact tracing apps in terms of COVID-19 and, the whole privacy thing. It was a huge thing, not only here in Croatia, but throughout Europe. What is your opinion on that?
Well, I think it was indeed a very hot debate. I think now the things are a little bit clearer. And what I can say is that together with other colleagues, we are working with the member states. I couldn't say really day and night, but we are basically having one meeting every 1 or 2 days. Since 25th of March, we had, I think, 34 meetings or more actually with member states to find a solution for the interoperability of the tracing app. I don't have a slide here. I had a very nice graph that I like a lot, which shows basically how those apps are working. So basically, they are exchanging only anonymous information. We had a very complex debate about how anonymous it is. I think they are basically really anonymous. They are generated. A Bluetooth identifier they are generated between the Bluetooth of different users when they are getting close within 2 meters and for more than 15 minutes. So the device is registered these encounters, let's say, and when someone is diagnosed with COVID, introduces a code given by the healthcare professional. This is the ideal scenario. There could be also apps in which the user declares himself or herself sick, which is not necessarily what most of the member states are supporting. So when So let's say I'm a user, I'm meeting you, okay? We are talking over a dinner, and then I'm getting sick. I introduce my code, and then you are getting an alert saying within the last 14 days, you've been close to someone who is COVID positive. Please take measures in order to get quarantine or to see a healthcare professional. You can get in touch with the healthcare professional by tapping here, etc. So it allows, it's very privacy preserving. It doesn't disclose the identity of neither of the infected person nor of the contact. Allows for the warning and allows also for the contact to get in touch with the healthcare professionals. Now, what was the most complicated part so far was basically interoperability between those apps, because we don't want people who are working and traveling in other member states to download several apps. We want to have one app and to be notified wherever you are in the EU. And we are very happy to announce that we have a solution for the so-called decentralized systems, where the matching is happening on the device. There is also another system which is called the centralized, which is in France, Norway, and Hungary, and it's used in a wide way, especially in France, where the matching is happening on the backend server of the healthcare authorities. Now, we have managed to find a solution, and we are working to build the right server and the right technical tools for forwarding different keys and for forwarding different information, basically, for the decentralized system. And we hope that basically most of the population will be able to travel with one single app within Europe. I think what is also important is that most of the apps, most of the countries are developing an app. Croatia is one of them. And is based on a privacy-preserving technology and allows interoperability. And we hope that this will contribute, if with a high uptaking, will contribute to fighting a second wave of pandemic.
Thank you so much, Ioana Maria. Stay on. I'm going to call on Ray to turn his mic on and his camera on.
Here I am. Hello.
Hi. Just in terms of what Ioana Maria was saying, I mean, we live in a period of time when privacy and security is one of the hottest topics for decades now, basically. And we have this pandemic, and we're trying to fight it, but at the same time, we're fighting the disease, but we're also worried about security and everything that Ioana Maria said. How comfortable do you feel in terms of apps that can track you, basically?
So thank you for this question, and I'm glad you raised it. You know, these are very, very difficult times. Normally, I would not allow over 100 people to look into my house. You'll probably see my teenage kids coming down the stairs. You know, I've never had a greater invasion of my privacy than, you know, at this moment, to be honest. But we do this. We do this because it's important and it's urgent and it saves people's lives. It's worth to highlight that these are voluntary. That's the most important thing. People take this on voluntary. Also, if they do use these apps, then you know, their identities are kept anonymous. Only they are alerted as to if they have come in contact with someone that was infected. And I think that is, you know, at the end of the day, something I would want to know so I could take the right actions and you know, not infect loved ones or, you know, my grandparents who are quite old. You know, I wouldn't want to do that. So the other important thing is that this is looked at very carefully by the European European Data Protection Board, so the data protection authorities. You know, they've looked at this, they've given an opinion on it. There are parts in the GDPR that allow this to happen. So people should not think their data protection has been at risk or has been compromised. It hasn't. I think these are being developed very carefully. I know the European Commission, I know Ioana takes data privacy and protection as the highest regard. And I would not propose anything if Europeans' data was at risk, Antonia?
Well, I think it's very important indeed to underline that the data protection part is extremely high. Again, I think I was mentioning basically that there were quite hot debates in the eHealth network whether the data is completely anonymous, because the capacity to link the data, the randomly generated identifier. So basically, the device generates every day an identifier, which is really basically randomly generated, a string of numbers and letters or signs, and every 15 minutes generates other identifiers. And basically, this is what is being monitoring this kind of in these meetings basically. So the device, when I introduce my code that I have been infected, the device of the people I have been in contact with, they go and fetch the keys, my key, generated for the last 14 days, and they are going and are checking is this number, string of numbers and figure correspond with something that I have met in the past 14 days. So clearly there is no possibility, no practical possibility of identifying the person. Now, several member states, for different reasons and for a very strict interpretation of the GDPR, they consider that the data are personal, but in fact, actually, the capacity, the possibility of identifying someone is nil. But in order to make sure that we at European level are taking really and the member states are taking all the possible measures in order to protect the patient's data, we treat those data as personal data. And this is why we are going to give a legal base to modify the implementing decision for the eHealth network for the processing of those data. Again, I repeat again, the capacity of identifying those people is basically nil. And in any case, it happens on the device of the person, doesn't leave the device. Okay, France, I think it's a separate example, but again, the anonymity of the person is guaranteed, and the person can, if they want, get in touch with the healthcare provider, but nobody from the health system knows who are the person who have been in contact with an infected person. It's their choice to call or not to healthcare providers to get more support or to get more advice or to announce that basically they want a test. It's also important to link it with the second wave and with the testing.
I mean, this is a very interesting, very hot topic, because most of the questions that we get right now is about privacy and about apps. And here's Julia. She's been watching us and listening to both of you. And she asks, who hosts the data of the tracing apps? If governments are developing the apps, to whom the data belongs to, and how is the data surplus being used? Do we have laws/agreements that protect patients? A question for both of you.
Yes. So I can try to reply, and probably Ray will complement. So the data is held on the device. It's held on the device. Your identifier is generated by the device, and only when I introduce my QR code saying that I have been infected, your device is going to the backend server of the health authority and fetches my key as an infected person, and then it matches those keys on the sorry, work-life balance obliges. I have my daughter.
Multitask.
Yes, always. Basically, the data is generated on the device. Now, when it comes to the cross-border part, because I think this is also important, those random identifiers are those keys, as we call them, are being exchanged between the backend servers of different member states. So that basically, I'm going to Croatia, and we meet. And I go back to Brussels, okay? And I'm detected positive. I introduce my QR code, and then ideally you should be able to be notified despite the fact that I got back to Brussels, okay? So in order to do that, my keys are uploaded to a server at a European level. But again, these are keys which are randomly generated. It's a string of signs. Nobody can link to the person. And these keys are basically forwarded, are fetched. I mean, I'm not going to enter into a lot of details because it's quite complicated technically, are being taken by the backend server of Croatia, and then you can, your device can go and fetch it from the backend server of Croatia and can basically do the match on your device and say, well, in the last 14 days, you've been in touch with a COVID patient. But it is very important that I do not have to download another app when I travel to Croatia, and you don't have to download the apps, all the apps of Europe, in order to make sure that if ever you have been in contact with a patient in another member state who has been identified as positive, you are being notified. So this is extremely important. I spare you all the diagrams that we have been doing for a lot of time. We have been working and discussing with the member states. They are very interesting. I think it shows a lot of the complexity of the system. But what is important is that people have to be reassured. The data, basically the identification is practically impossible. There is no tracking. We are basically tracing the contact. So what it shows is it doesn't show where you have been. It doesn't show what you have done. It shows only if you have been in contact with someone who has been positive, in order to allow the people to get tested, to get quarantined, and to get the best treatment, and to avoid spreading the disease, because I think this is the ultimate goal, to avoid the second wave.
Okay,
yeah.
great.
Yeah, very much. Just to emphasize, and Ioana covered it quite well, we have a paper, just go up to our website, where we make sure that these apps are designed with privacy in mind, with the GDPR in mind, in its design. And, and also that, as Ioana was saying, it's using all the different pseudonymization, aggregation, anonymization techniques, such as rotating identifiers, making it very difficult to track, if not impossible, and, state-of-the-art cryptography and other type techniques.
You know what I personally find very funny, not very funny, but funny, the fact that most of us use Google Maps on our phones, and my phone at all times knows where my car is parked. So basically, it knows where I am at all times. And here we are worried about these apps that are made to keep us safe. And we're worried about privacy. But I guess that's just a sign of the times, I guess. We do have one last question. It's going to be for you, Ioana. Can we just move the screen up to the questions? Yes. How EHDS is positioned versus other European cloud activities such as Gaia X? And it's a question from Gerhard.
Okay, thank you very much. So maybe just to go, if I can go back to the previous discussion about the apps. If anybody is interested, on the website of the eHealth network, you can find all the documents, including with technical specifications, with guidelines. And I think that's interesting to read. And for those who want to enter into details, that's a good reading. On the European health data space, we are not aiming basically at building a cloud on Rue de la Loi in Brussels. I think this is very important to underline. What we are aiming is to basically to federate existing infrastructure in the member states, and to help member states build existing ones, new ones. In my slide at a certain point, there was a diagram with some national contact points, and a circle linking those national contact points. This is a little bit the type of approach that we are aiming also with the European health data space. We have done this already for the, I think it's a little bit, yes, there. No, it's that one. Yes. So for the exchange of patient summary and e-prescription, which is also part of the European health data space, how the things are happening. So a doctor in the hospital, in hospital B, when I go to Croatia, let's say, I'm going to emergency, and the doctor wants to see my patient summary, my previous diseases. And he or she is asking the system through a national contact point in Croatia, which contacts the national contact point in Belgium. By the way, Belgium is not yet in. Croatia, yes. And he's asking, I would like to see the patient summary of Ioana. And the system basically puts together my patient summary and sends it to the through these national contact points through the hospital in Croatia. So more or less, I think we are aiming to have something similar of federating, of putting together the infrastructure at national level. Now, where this will be one national contact point, for instance, involving the data permit authorities like FinData, like French Data Hub, etc., that's a discussion that we still need to have with the member states. What kind of infrastructure the member states will have at the national level, this is also a discussion that will basically evolve. Probably most of them, they will have clouds. How they will use this we'll have to see. But it's very important to make sure that we have a very trusted governance. And I think what has happened in Finland, France, Denmark, Portugal, etc., with those data permit authorities, which allow for a trusted authority to query the data and put the data, be a broker between the researchers or the policymakers and the electronic health records and registries, that is extremely important. And our aim is to put together basically those brokers or those data permit authorities and to be able to exchange queries, not necessarily data, personal data, but to exchange queries about different areas. For instance, just to give you an example, because it was a lot of discussion, for instance, about the use of ibuprofen in the COVID. One may decide to do a pan-European study about the side effects of the patients, of the COVID patients who took ibuprofen, so or hydroxychloroquine or whatever. And then these queries could go to those national contact points, and then they could get the information from their system and share with the others. So the idea of the federation, of respecting the national laws, is extremely important in this infrastructure, and we have to make sure that we have the right governance at national level, but also at the European level. And this is what we are trying to set up: the governance, the infrastructure, not necessarily centralized, and the rules for the European health data space, trying to bring together what exists already at national level.
Thank you very much, Ioana Maria Grigor. You were amazing today. Thank you so much. It was a pleasure to have you with us today. Hopefully, we're going to stay till the end. We have a lot of interesting speakers coming. Let's move on with our program. As you all know, during COVID pandemic, use of digital tools in healthcare increased drastically, from teleconsultations to utilization of chatbots, AI assistants, mHealth apps, e-prescription tools, data sharing solutions, and many others. Digitalization of healthcare is a trend that has been in constant development for more than a decade now. Let's hear a few examples of the best practices of this digital transformation. First up is Ivan Malenica, Croatian Minister of the Ministry of Administration, and he will be presenting Andrija. Andrija is a Croatian chatbot, digital assistant, and he was born in a way during COVID-19 pandemic. Mr. Malenica, can you hear me?
Yes, I can hear you.
Good morning. Good day to you, sir. I'm not sure what time you got up this morning. I can hear you, but I cannot see you yet. Let's see if your camera is operational.
Yes.
Oh, yes. There you are.
Can you see me?
Yes, yes. You're fine. So as I said, you're going to be presenting Andrija. It was a huge hit here in Croatia. Everybody was talking about Andrija. So let's see who Andrija is to all of our European guests today.
Thank you. Hi to everyone. Andrija was created as a response to need for a quality cooperation of the state, the Ministry of Health and Citizens of the Republic of Croatia. The project Andrija Digital Assistant was managed by the Ministry of Public Administration, which has been implementing the digitalization of public administration, and the solution was designed by a team of experts headed by epidemiologist Professor Branko Kolaric, with the technical and IT support of the joint forces of domestic IT companies. Communication with Andrea is very simple. Citizens contact him on WhatsApp to start the chat. In contact with the citizens, Andrea provides assistance by educating people how to recognize the symptoms of coronavirus infection through self-assessment. The information provided helps citizens to better understand the risks of potential infection, when not to worry and when to take action for their own and other people's sake. Through this chat, citizens are able to receive all information in one place. During the pandemic and restrictive measures introduced, Andrea was being continuously upgraded. Andrea gave citizens the possibility of self-assessment, information on a current measure, instruction for the visitors and employees of senior citizens' homes, instruction for people arriving in or leaving Croatia. It offered the possibility of reporting the symptoms of infection in the household and provided important telephone contacts. When faced with the problem of the virus spreading in senior citizens' homes, we reacted promptly with an upgrade to Andrea. Professor Branko Kolaric, who taught Andrea his first citizen-oriented skills, is also the head of the reference center of the Ministry of Health for Senior Citizens, Health Protection, and epidemiologist competent for all senior citizens' homes. He taught Andrea new skills to provide the employees of senior citizens homes with a better understanding of the protection and testing protocols. By communicating with Andrea, the employees of those homes were also able to receive clear information on their current status and what to do properly, follow the protocol and the security instruction and measures of the Croatian Institute of Public Health in cooperation with the Ministry of Demography. Demography, Family, Youth and Social Policy. Andrea provided similar assistance to the families of the residents of those homes who were not allowed to visit. The goal of creating Andrea was to relieve the burden on epidemiological service, which were receiving over 50,000 questions on a daily basis at the time. On top of having to work on recommendation and measures, within a few days, Andrea reduced the burden of those services by as much as 25%. During coronavirus pandemic, Andrea answered over 800,000 questions of concerned citizens who were very satisfied with this service. I believe it deserves special mention that all the Croatian companies involved in designing Andrea participated voluntarily and free of charge to give the contribution to the national efforts to contain the epidemic. As a Minister of Public Administration, I am extremely pleased with the prompt reaction and introduction of new tools for communication with citizens. Apart from Andrea, the Ministry, in cooperation with the Civil Protection Headquarters, managed to put in place the system of e-passes within only a few days to enable citizens to leave their place of permanent residence despite lockdown in case of justified reasons. Our data indicates that the system provided to be more than successful. Out of approximately 2 million e-passes, more than a half was issued to businesses, which indicates that we managed to maintain some economic activity. COVID-19 changed our everyday life, forcing us to adjust our lifestyle and the way of functioning. With the digitalization of public services, which has been a field of our intense work for 3.5 years, we are heading in the right direction, and we intend to continue with it. In a post-COVID future, assistant like Andrea will become an integral part of our system and make our daily communication with citizens easier. So thank you. I wish you a good conference, and see you maybe next time.
Thank you very much. I do have one question. You said some amazing stats about Andrea.
Yes.
You said, if I'm not mistaken, 800,000 questions?
Yes.
Oh God, that's amazing. What is the future of Andrea? Once we beat this pandemic and COVID-19 is no longer an issue, what's going to happen to Andrea? Are you gonna reprogram him and use him for something else? Is that the plan?
Well, we are thinking about using it in public administration, because it's based on artificial intelligence. So we are planning to use artificial intelligence in public administration, and especially communication with the citizens.
Well, thank you very much. Good luck with Andrea and all other Andreas that you have in the future coming up. Thank you very much for taking the time and to talk to us.
Thank you.
It was Mr. Ioannis, Croatian Minister of Public Administration.
Thank you.
Top is Jean-Paul Detis, founder and CEO, OncoDNA. In 2004, Mr. Detis founded DNA Vision, the first company in Europe to provide the pharmaceutical industry with accredited pharmacogenetic test. I don't know if I totally mispronounced it. Jean-Paul is gonna correct me.
That's right. Correct name. Pharmacogenetics, the prediction of the response of a drug based on the DNA profile of the patient. Yeah.
Was I right? Did I say everything right?
Yeah, very good.
Oh, Jean-Paul, great. It's so lovely to see you and to hear you. And if I'm not mistaken, we're going to begin your presentation with a short video, then you're on, okay?
Okay, perfect.
Okay.
Yes, thanks for this introduction. Maybe for the slides, could you advance the slides for me, please? Or I take the control? I don't know. So I will explain the link to the digital health. As you know, cancer is a complex disease, and there are so many information, and that's for the benefit of the patient, but there are, here you have some numbers, there are so many new therapies. We talk about targeted therapies, immunotherapies, and also some new understanding about the difference between cancer cells and so on. With the exploratory of the whole genome of a cell, we understand more the pathway and so on. Now, in this slide, we talk about 50 actionable genes. It's even no more because you need to see the tumor mutational burden, the immunotherapy to predict the response of immunotherapy. So the meaning, the thing that is very important is becoming more and more complex. And here you see a nice team of young oncologists that understand everything and that we help them. But the reality, next slide, the reality is that in many cases, the decision is still done by one guy that must cover all type of cancer. Here in Belgium, we have the chance to have a good healthcare system and with nice reference center, but you can have also local hospitals so that with one oncologist seeing every type of cancer. Yes, you will tell me that there is the guidelines, but the guidelines are just statistics and only for the big cancer. And the difficulty is that when you try the first line, you have only 30% of good response. After you go to the second line, and after it's trials and error. And that was my concern. So when I started OncoDNA in 2012, I work in the field of DNA sequencing since more than 16 years. Why all this information is not available for the oncologist? And or to guide best the patient, why the treatment that you schedule in the third line will not be the treatment that you put in first line to give the maximum of chance for the patient based on the molecular profiling of his tumor. And that's really what we are doing at OncoDNA now since 8 years. So we've treated more than 20,000 patients around the world, with always all the reports that are based on the internet, where the oncologist can order the test, he can share with the patient, discuss the results online with the patient. But really, what is our vision is really to find the best treatment based on the maximum of information about the tumor of the patient. So we started more as, it's a new term called theranostic, the diagnostic to choose the right treatment. But beyond that, we are collecting a lot of data about the evolution of the patient cancer. And we saw a lot of benefit to take experience from other patients to guide the treatment from other patients. I will illustrate that in a few slides, but very fast. Just the organizer asked me to illustrate with a case. Here we have a Croatian patient that we have saved 3 times his life since 2015. I think it's a quite impressive case. We have in testimonial the patient, the oncologist present the case to our annual conference. Just to explain you, we started to analyze this patient in 2015. We received what we call a block of biopsy, a block of tumor. He was in stage 4, so very advanced cancer, in palliative care, so failure after 3/4 line of treatment. So no more hope, going to palliative care. We received the tumor here in Belgium. We do the DNA profiling and other tests, and we found an interesting mutation. You see a curve here that is called ctDNA. So it's when you have a cancer that is advanced, you have also a tumor of DNA that are circulating in your blood. And that could be an indicator of your response to the treatment. And here you see blood samples is what we call a liquid biopsy. We analyze the tumoral circulating DNA that are in the blood of the patient, and it's personalized based on the tumor of the patient. And you see there that there is a response until April 2016, July. There we detect in the blood that the tumoral DNA was becoming more higher. Even that in the CT scan, you detect nothing. So the CT scan, the scanner, the imagery, there were no tumor back because the tumor has disappeared before on the CT scan. So that was an alarm, which was confirmed 2 months after that on the CT scan that the tumor was coming back. The oncologist decided to put him on immunotherapy, but we had no clue of that. The markers were not sufficient enough, but why not? he has a partial response between 2017 and end of 2017, and after the cancer was coming back, detected again in the blood. And there the patient has a chance to have a new mutation, mutation ESR1 for a treatment that was still not authorized for that. So in fact, we detect 6 months before the official authorization of this drug in this cancer that the patient could be responsive to this drug. So the oncologist asked special authorization to have access to the drug. He can succeed to have the drug. And after, the patient was responding well, and the patient is still alive. Danko, no, he's still alive now since 5 years. That a guy that was in palliative care. So it's a spectacular case, but we have made that many times now since the foundation of OncoDNA. But you see, it's many data points, many interaction, strong follow-up of the patient to be able to transform this disease in a chronic disease and in good condition. So what was the bet? It was to put online oncologists. I know we have a community of 4,000 oncologists around the world that connect inside of we have 2 platforms, OncoShare and OncoKDM, so we can see online the report. The report is not one-page report. There are many information about the clinical trials that are available, all the mutations discovered in the tumor, what are the drugs, not only the drugs approved in this cancer type, but approved in other cancer types. So we have more or less of 30–40% of our oncologists that are doing what we call off-label use of the drug. And there is always a sharing of the report with the patient, and so the patient can ask questions also on the platform. The oncologist can share the report with other colleagues. They can discuss online about the case. And because sometimes it's best to have also sharing of experience with other oncologists, pathologists, and so on. And so what is our final goal? Our final goal on OncoDNA, and after maybe it will be in the question session because that's the difficulty also. We are collecting different cases. We have one is coming from the diagnostics. We have the informed consent of the patient, but we have also some cases where we don't have the informed consent. It's the laboratories that are sending the data. But really, our goal is to be able to do patient matching. So an oncologist in Madrid can look inside our database. Profile that is patient profile that is similar. So same mutation discovered in the tumor, same ethnicity, same previous treatment, and to be able to the oncologist to let him to contact the oncologist maybe that is in Paris following another patient, the similar patient, and so that they can exchange together what was based on the recommendation of OncoDNA. You should put this patient now on immunotherapy. What was the outcome? And that's really strong that think that it will be the future of this kind of medicine, because it's the sharing of the experience, the concept of the one patient clinical trial, because each cancer is different. And to address that, you need to have this sharing of information, to have the most similar patient having the same previous history and so on. And that's really the final goal of our platform. But the main question behind that is that we are in Europe with the difficulties to have there is a GDPR also, but there are also local regulations between each country that are different. If you want to work with Italian patient to do the interpretation, the Italian law requests that the data are stay on the Italy. Not in Europe, it's in Italy that you must show that you can do the interpretation on the Italian ground. Germany has also some specific law due to the genetic background. And that's the complexity that we face to be able to do this kind of nice tool for the future of the treatment of cancer. There are some limitations that we see as a scale-up from one side, but maybe all the big players that you see more on the digital, the GAFA and so on, maybe they don't have the same limitation and not have the same questioning. Maybe I anticipate some question, maybe, or I don't know.
Well, I do actually. I do have one question, if it's okay with you. What was it, I mean, listening to you, to all that you have said, I mean, it's very, what you do is very, very special, and I guess there are so many people right now that could find hope in finding a solution in what you do. What is the biggest challenge in terms of OncoDNA?
If I look to the company, that it's not also on the data sharing, but the biggest challenge is also the change in the field where there are takes time. The lobby of the diagnostics, again, the pharmaceutical companies is not the same power. And so, you have giant like Roche that is evolving in diagnostics and pharma, so they have more power to change the things. But now we have a first EU state, is Luxembourg, that is reimbursing our solution. But you know that Europe is complex. I don't remember exactly the number of EU states, but we must do the same in each EU state to show the benefits of this solution, to where there is also a lobby of pharma to not change the big things. So when immunotherapy, the cost of immunotherapy is more than 100,000 euros per year for a patient, and if all the rest staying live, they don't want to have limitation that maybe we detect the immunotherapy will not work and that we go to another direction if they have the authorization. So there is a strong lobby of the pharma and the diagnostic that is, but maybe with the COVID could change the things, that they see that to invest more in the detection, more on the guiding tools could help to spare some money on the drugs that can cost that can be very expensive for the different social security systems.
We do have one question from our audience. This is Marta. Who pays for the service? The patient?
We started historically by the patient, and so we have still a lot of patients paying for the money. So the price of the different tests are between 1,000 euro and 5,000 euro, depending on what we analyze. But we have different insurance, mainly, for example, in Anglo-Saxon countries, in UK, for example, Bupa and so on are reimbursing our solution. But we are very present globally, so even in Malaysia, we have insurance reimbursing us, in Australia. And we have now starting to have, like I mentioned, some EU states, Luxembourg, that are reimbursing for all metastatic patients.
Mm-hmm. Thank you so much, Jean-Paul. Jean-Paul Detif, founder and CEO, OncoDNA. Thank you very much, sir.
Thank you for attention.
For being with us today. Let's move on. With us today is Ivica Belina, President of Coalition of Associations in Healthcare, or in Croatian, Koalicija udruga u zdravstvu, Croatian umbrella patient organization. From 2016, under his leadership, Coalition founded informal platform of cancer patient organizations, onkologia.hr, for increased impact of cancer patient advocacy on national level and greater impact on cancer policy. Mr. Belina?
Hello.
Oh, hello. I can see you and now I can hear you. These are your 10 to 15 minutes, so take it away. Good luck.
Okay, thank you. So basically why I'm here today is to present what we did in this COVID-19 crisis, because there was a problem with patients that are in remission and they finished the treatments. They couldn't get any control exams. And also the new patients were not recognized or diagnosed. And I must say, and congratulate to the healthcare system that all the patients that were actually in the treatment, active treatment, received everything they should. So we tried to provide some information for the patients, and we thought, what could we actually do? And then we decided to make this web page, which will contain all comprehensive information about cancer care, the possibilities for getting cancer care. in these conditions, and also all the safety information for the cancer patients, how to get these cancer services in a safe manner. And to be able to do that, we propose collaboration to the Ministry of Health, to the Institute of Public Health, to the healthcare professional organizations, other patient organizations, hospitals, and I have to say we got 30 hospitals on board, and we published all this information on our webpage just to tell people where and how they can get any service, and to reassure them if they had to wait for something and they had just like phone call consultation or email consultation, that is okay. They should be patient. And it actually worked.
I'm sorry, Mr. Bellina, I'm sorry to interrupt. I just wanted to let you know that I know that you have a presentation. If you want to turn the pages, turn the slides, you can, because the controls are on your computer.
Okay. Do you?
Page up, page down.
Okay.
Let's try it together.
But no, it's not working.
Hold on.
Okay.
We're gonna take control back.
Okay.
And we're gonna try it out together.
Okay, let's see. Okay, so this is the snapshot of that page.
Anytime you want to move the slides up or down, just tell us and we're gonna do it for you. Okay. Okay. Thank you.
You're welcome. So this is the starting page. We had general recommendations for cancer patients, how they should behave in a healthcare system, and this was from recommendations from different healthcare professional societies, but also recommendations from the National Institute for Public Health. Then we had information about the coronavirus and some concrete instructions for the patients, how they can get the best cancer care. One of the main features was actually the possibility for questions, for Q&A, and we would publish all the frequent questions to the people, but of course everyone who would have a question would get a separate private answer. So can we move a page up, please? Yes. So I already talked about this, why we wanted to provide this relevant information, and we were actually updating the web page whenever anything changed, and I think we quite managed to do well. Could we go page up, please? Yes, thank you. So this is what I was talking about also, how we try to be comprehensive. So including all of these different stakeholders was very important, and getting the relevant information from them and publishing them was crucial at the moment. We also was always on the lookout for any available literature and any European and international recommendations. For instance, we didn't have any for palliative care, so we were looking for those informations and providing them for patients. And of course, I was also talking about questions and answers. So please, could we go page up? Thank you. So what we learned from this, that this digital communication actually changes the role of cancer patient organizations, but also changes the communication inside of the cancer patient society, with providing this one relevant source of information, which leads to very specific different sources of information. it's connected with them. And we also had some interviews with oncology leads, which we published. We also collected some patient stories and patient testimonials. And what was very important, that it was very interactive, because on social media and through emails, they could actually influence the content of the web page. And one important learning from this is that actually it deleted the competitiveness among patient organizations, because we are all like elbowing, I'm doing this better, I'm doing this better. And this is actually one place when we presented what are the services that actually patient organizations are providing for the patients. And all these pages were connected with this main one. And this built this sense of unity and contribution. So I'm open for your questions now, if there is any.
Again, I have a question. I'm the one in charge of questions today. I just want to remind everyone who's watching, you can also take part in today's conference by asking questions. You're going to see on the right side of the screen, there's a Q&A section. Feel free to ask a question. My question is, what did the people visiting your site or sites wanted to know? What were the questions that are asked most frequently?
Okay, so we had a group of people who are immunocompromised, who are in the treatment, and members of their families had to go to work, like ladies working in the grocery stores. And how should they behave in this situation, and how could they protect their family members who are immunocompromised? We also had a lot of questions about when it's safe to visit the cancer patient, because this social distance was very disturbing for them. They were lonely and they were isolated. Also, where and how they can get proper treatment at the moment. Where can they get some diagnostics? Are the drugs available? Is it safe for a longer period that the drugs will be available? And this was the majority of the questions.
We live in a pretty traditional society here in Croatia, mostly, and I know that most of the people, when talking about healthcare, they're used to getting dressed, getting in their car or public transportation and going to see their doctor. What this pandemic made us do is to use online resources more than ever. Do you think that this whole situation is gonna change the way that we think, and that we're gonna use services like the one that you provide more and more?
Yes, well, I think this was for as much as it was a very difficult time, but it was it was a time of great learning, and I think that people changed a bit with their attitudes towards health. I think that at the moment they are much more open to the information about the health and the healthcare, and also this. Well, we are a country of differences in accessibility of healthcare, so this hasn't changed, unfortunately. And we had many e-solutions in the healthcare which were not accessible in all parts of the country. So you had hospitals where you can be just referred via email with all your documentation, but in some other hospital, you had to go there physically and bring all the documentation with you. And I think this is something that we really need to learn upon and build upon in the future.
Thank you very much. We do have one question extra, but I would ask Melanie. She's in our audience to ask the question. Again, we need a full question because Melanie, what we're seeing right now is just you saying, I just asked a question regarding patients' organ competitiveness, something Ivica Belina talked about. Yes, but we actually need a question because you didn't ask the question. So yeah, ask the question, and then Mr. Belina is going to stay with us, I think, for some time, and we may have him back on to answer your question. Thank you very much, Mr. Belina. It was a pleasure. Okay. I'm sorry, what?
Melanie's asking the question.
Oh, Melanie, can you? Okay, so I'm sorry, Mr. Belina, you're still here. Okay. So
Okay.
Melanie said, I just asked a question regarding patients' organ competitiveness, something that you talked about. Can you provide more details about this? Thank you, she said.
Yes, okay. So we are a small country and we have like more than 200 patient organizations in Croatia. And you have very strong organizations in like, I will take my answer for example. We have few very strong organizations which are always very competitive about what they're doing, about their awareness campaigns, how they're perceived in public, who will get more public space. Unfortunately, we are also competing about the income or the sources for the financing. So this actually changed this because they all could participate. We specifically explained to the visitors to the webpage what services are provided by specific organizations and how they can contact them. Some of them are working in the local settings, some of them are national. So I think that changed a bit, and this collaboration was more fluent and more natural. I hope I answered your question.
Thank you very much. I'm sure you did. I think that Melanie is more than happy to get the answer.
Thank you, Melanie.
Thank you. Thank you very much. Okay, it's time for our panel session, which is called The Role of Digital Tools, Oncology, on Oncology, the Reality on the Ground. And it will provide insights on the role of digital tools playing an important role for care of cancer patients. Particular focus will be placed on the impact from COVID-19. The panel will be moderated by Ray Pinto. He's basically my co-host today. Once again, Ray Pinto, Digital Transformation Policy Director at Digital Europe. Ray, you there?
Yes, I am. Thank you very much, Antonia. And if you ever want to start a new show with me, happy to do so.
Definitely. We're going to talk about it later. It's done. It's done.
Excellent. Excellent. So it looks like we still have about 130 participants. So thank you to all of you for staying on. Now is really the opportunity for us to drill down in far more depth with a great panel that you see before you. We're going to ask a few rounds of questions. We're going to give them an opportunity to introduce their area. We have panelists that are calling in from California, so super early for people like Bryce. Thank you, Bryce. And you can, of course, ask questions in the Q&A. I'll be monitoring that and try to weave it in as much as I can over the next little bit that we have. Do stay on until 12 o'clock because we do have the Croatian government who will be defining the presidency conclusions coming on. So please do stay on board till the end. So I would like to just quickly go through. We have Antonella Cardone, who's the director of the European Cancer Patient Coalition. She will be followed by Mike Holmes, who is the vice president of Global Oncology Medical Affairs at MSD. After him, we have Darine Ganem, who is the global head of personalized healthcare and patient access at Roche. And then we have Bryce Olson from Intel, who is a global strategist for health and life sciences, and then a member of the European Parliament, Susanna Solis, who will conclude the first round of questions. So if we can move to Antonella first. Hi, Antonella.
Hello, can you hear me?
Yes, we can. And there's your camera. Perfect. And if I can ask, I think, hold on, I have to power the slides. Perfect. There we go. Okay, great. So Antonella, hello. Thank you very much for joining us. You are the largest cancer patient umbrella organization in Europe, as I understand. You have 450 members across 46 countries, which is very impressive. And I was watching a video recently with you where you highlighted that it's important cancer patients are getting the best treatment in this crisis. And of course, they should have the opportunity to return to normal. I'll pass it over to you if you can take a few minutes to give us an opening statement. Thank you.
Yeah. Thank you, Ray, and good morning again, everyone. I would like to start reminding that the causes of COVID-19 related deaths are not clearly defined yet, but data from Italy showed already in the first weeks of the outbreak that more than 20% of all COVID-19 mortality was among cancer patients. And if we consider that as of today, we have about 9 million cases and about 500,000 deaths across the world, this sum up to significant figures for cancer patients and justifies why cancer patients are among the highest risk population, and also why cancer patients were, in the midst of the outbreak, rightly advised to stay at home and do not go to see their healthcare professionals unless strictly necessary. The consequence of this was that the screening or follow-up consultations were suspended for an unknown period of time. And this generated psychological problems and distress among the cancer patient communities. But not only that, studies now are starting to come out showing the results of the lack of screening and follow-up. In particular, a study that was published a few weeks ago by UCL suggests that there will be a 20% spike in the number of facilities in newly diagnosed cancer patients due to late diagnosis or treatment. So the study estimates that a possible 18,000 additional cancer patients may die next year in England. So that's only England, not the whole of the UK. And the rise in deaths is partially due to the reluctance of patients to go and see their GPs and to be referred to hospital because they fear catching the virus more than the potential tumors. In some cases, cancer patients delayed consulting the doctor because they did not want to add to the burden of the health system. So if we had in place proper protocols differentiating pathways in hospitals or infected and non-infected patients, and most of all, if our health systems were prepared to extensively use telemedicine or other forms of digital technologies to support the patients at home, many lives would have been saved during the emergency and in the long run. Unfortunately, despite the fact that there was a previous work specifically describing the potential for using telemedicine in disasters and public health emergencies, no health systems in Europe or in the world was prepared to exploit digital technologies for COVID-19. And no telemedicine program can be created overnight. So a central strategy is needed at EU or country level. So what happened in most cases is that in the emergency and on a personal basis, some healthcare professionals set up their own pragmatic telemedicine system, calling their patients on the phone or via computer with a webcam. After a few weeks, more systematized telemedicine systems have been put in place. All this has shown how extensively non-prepared we all were. So telemedicine would have helped sorting patients before they arrive in the emergency department, as forward triage could allow patients to be efficiently screened. Telemedicine protects patients, clinicians, and the community from exposure. Telemedicine could allow healthcare professionals and patients to communicate 24 hours, 7 days a week using smartphones or webcam-enabled computers, can detect respiratory symptoms, and telemedicine can be used by healthcare professionals in quarantine, working from home, taking care of patients in their homes. Televisit systems are also being used for hospitalized patients to reduce exposure risks for visitors and staff. For instance, in Italy, tablets were used by several patients in hospitals or elderly people in nursing homes during the outbreak. So quickly, what were and still are the challenges with telemedicine? As said, telemedicine cannot be implemented overnight. There is a need for a central strategy and operational systems in terms of payment, credentials, and staffing. Healthcare professionals need to be trained. A certain level of health literacy is needed among the general population and even more so among cancer patients. So disasters and pandemics pose a unique challenge to healthcare delivery. Though telemedicine and telehealth will not solve them all, it's well suited to help reducing the burden and save lives. So I'll stop here for now, and I'll be happy to take questions as we go along with the discussion. Thank you.
Antonella, thank you. Thank you very much. A lot of what you said is incredibly sobering. We have seen some statistics in France, for example, where there was a 40% increase in telehealth. I don't know what the divide was in regards to consultations or treatment, where was it telemedicine, where was it telehealth, but there was an increase. But I'm guessing, listening to you, that not much was those numbers were for cancer patients, which is very sobering. I want to ask you, the Commission is now looking at a strategy for Europe beating cancer. How much of your recommendations or the push to encourage the health systems to be more digital, adopt more digital, provide skills, are you seeing that in any of the discussions that you're having? Will we go down that road where this will actually be a focus for a government strategy, where previously digital was not always really the priority number one?
Well, definitely now with the COVID-19 situation, the European Commission will have to address the possibilities, the opportunities provided by digital health. It cannot be ignored, and we will definitely review our priorities based on this. We've already done so, as it is so clear and obvious that telemedicine would have helped so much keeping the pandemic under control, reassuring cancer patients, would have helped with reducing the gap in between follow-up and screenings. So telemedicine can be helpful, cross-cutting all the different stages or pillars of the cancer plan. So it's definitely going to be a priority. I see it already.
That's great to hear. But even more sobering is all this talk about the second wave of COVID. We don't know how many months before or if there is a second wave that forces us all back to confinement. if we assume it's really just 6 months, as the media pundits are saying, what would we have to do urgently? What is the must-do now strategy for health systems?
Yeah, thank you for this question. I mean, now, as I said, telemedicine and programs cannot be developed overnight, but now we have a few months to be prepared. So we need to train healthcare professionals. We need to inform and empower cancer patients and maybe even the general population on the use of telemedicine. And we need definitely to share best practices across Europe and maybe also from the US, if there are any there, as they are normally more advanced on the use of telemedicine. So I think those are the biggest steps. So we need to prepare by training, informing and empowering, and setting up the right tools and systematize the right programs and tools across the health systems in Europe, in different countries.
Thank you very much, Antonella, and I really hope everything you said is going to be listened to. We are recording your statements, by the way, so we will share it on our websites and communicate it as much as possible. Can I ask you, because you have so much experience and you're tied into all these other organizations looking at cancer patients, we've seen digital tools used in various forms for business, for education, for government interaction. But in this case, what are the digital tools? You don't have to name products, of course, but what are the digital tools that are necessary?
The digital tools. So first of all, we need to have digital tools to allow patients to communicate with the healthcare providers. So those are the ones that permit a follow-up, so that there is no need to postpone follow-up visits. Then monitoring from distance the health of the patients, the conditions, the general conditions of the patients. Then, of course, also these apps that are going through now for keeping track of the COVID and the contacts that people have. Those need to be perfectionate in a way so that first of all, patients can maintain control of their own data. They need, so first of all, they need to know the data that are shared and keep control on them. Then I mentioned also there are tools that can be used to triage the patients before entering physically the emergency department. So I mean, there is all sorts of tools now that can be exploited, not only for diagnosis, but also for follow-up and making sure that the proper treatment is provided throughout an emergency like the pandemic or the risk of a second wave that we are all expecting.
Thank you very much, Antonella. I could ask you questions for the whole panel, but I'll just keep it to one or two more because we have a great panel ahead of us. You talked about the devices and tools are already available on the market. There is the medical devices regulation that does provide heavy scrutiny of medical devices to enter the market, and there's notification bodies that again provide a large amount of oversight. For example, in AI, the algorithms and the AI systems are being heavily scrutinized before anything goes onto the market. In some cases, data that was used when these products were approved sometimes restrict the data needed on an ongoing basis. to refresh these AI systems on a regulatory side of things. I think essentially what I want to ask you is, do you see any regulations that are preventing any products or devices getting onto the market faster, or the products are there, or what other products do we need to be developing to help cancer patients, in your opinion?
Well, we needed to homogenize as much as possible the gathering of data, as now too often across member states or even across different institutions in the same country, the data are not comparable, they do not speak to each other. So we needed to avoid the silos gathering of data. We needed to make sure that the data can be easily shared. And the GDPR was supposed to develop a trust on the different stakeholders and make sure that there is an homogenized system to protect the privacy of citizens across Europe. But then, there is an article allowing member states to tailor the GDPR to their own country, and that this is provides interpretation to different countries, and it is often a barrier to share data across border. And I must say that, as it was already said in the discussion before, we use our phone without really being aware of how much of our own data are collected and used. We don't know for what reasons they're used and for what benefit. But then when it comes to research, we are in a way protected by institutions on how data can be shared, should be shared, but too often it happens that those data are not available for the research and then for the ultimate benefit of cancer patients. And this is it's a barrier that we should all together work for avoiding, because it happens too often that data cannot be shared for research.
Antonella, thank you very much. I think these last points, I think all your points are going to be touched on this panel. Those last points on Article 89, the difficulty of reusing data and sharing data over borders will probably be a recurring theme. Stay on the panel. We'll get back to you. I'm now going to move to Mike. So, Antonella, if I could ask you just to turn off your camera. And Mike, if you can turn on yours.
So, good morning, Ray. I hope you can both see me and hear me.
I can see you and hear you perfectly, Mike.
Very good.
Thank you for joining us. You're the Associated Vice President, Head of Oncology for Medical Affairs, covering most of, all of Europe, Middle East, Africa, I believe, and China, I think.
Yeah, in fact, my position, I have a global position at MSD, okay. so kind of covering everything.
Great, excellent. Thank you for joining us. And I also see that you're a trained surgeon for a couple of decades.
Yes, thank you for mentioning that. That's going back a fairly long time ago. I've been in the industry for 20 years, but the first 10 years of my clinical life were actually devoted to training in surgery. So I suppose I still sometimes take a kind of surgical perspective on life, which I think can be helpful at times.
Thank you, Mike. And so I'm going to pass on to you for opening comments. It'd be great to better understand, what are your experiences around the world? What are the digital tools, that are working? How easy is it to provide cancer?
Ooh, Ray, I don't know whether you can still hear me, Ray, but I seem to have lost connection. I don't know whether it's Ray I don't know if we've lost connection with Ray. I don't know whether you guys can still hear me.
Yeah, we can still hear you.
it's Vincenzo from Digital Europe, and Ray indeed appears to have a problem. So I would suggest is for you to elaborate on your opening statement and see if Ray manages to get back.
Okay. Well, first of all, thank you for the invitation to this panel and the opportunity to participate in this meeting, which I think is absolutely critical at this time of this terrible pandemic, which is having effects on all of us, on our daily lives, and very importantly, having a huge impact, unfortunately, on patients with cancer. And just thinking about my opening statement, there were 2 points I wanted to make initially. So MSD as a company has been exploring digital avenues and including telemedicine and working with various outside organizations to think about ways that we can bring telemedicine to patients. But I think it's true to say that this COVID-19 pandemic is really forcing everyone to accelerate ways of finding digital methods which can enhance and provide cancer care. And it's really boosting innovation. I think it's making us feel the true urgency of what we need to do. And Ray had mentioned a second wave. So I have no idea. I'm not a virologist. I'm a cancer expert, not a virologist. So I have no idea whether a second wave will come. But I do believe that we have the opportunity to be better prepared should that happen, maybe in the winter months. Again, I'm not an expert on that side of things, but we should use this opportunity now to do two things: to be better prepared in case there is a second wave, but also to really accelerate our digital innovation. And I think European Beating Cancer Plan, which has already been mentioned in this discussion, that's a really good opportunity, unique opportunity, I would say, to look at digital learning from the COVID-19 and how we can really use this to enhance patient care. And in my opening statements, I'd like to just briefly touch on three critical elements. The first one is actually the impact on patient care. Antonella had actually already mentioned the University College London Partners analysis of the NHS England data that we already have. So NHS England do a good job of collecting pretty accurate data. And in addition to the potential for 18,000 increase in deaths that Antonella mentioned, it's also worth saying that there's been an almost, during the month of April and May, which were really challenging for us here in the UK, there was almost an 80% drop in referrals from family doctors to cancer centres, which is absolutely huge. And also importantly, there's almost a 60% reduction in the delivery of chemotherapy cycles here in the UK. And I'm very well connected with the UK oncology community, and what we were hearing that really for April it was almost impossible to run oncology services in any realistic way in the UK, which I think is common in the US. We've seen similar situation in the US as well as many countries across Europe and also initially in China as well. And in fact, according to the UK Cancer Research UK, there's almost 1 million people, almost 2 million people waiting for screening. We have good screening programs here in the UK, but they've been completely delayed. There's almost 300,000 patients who are in the waiting list for urgent referrals, which is of great concern. And around 22,000 patients have suffered a delay in treatment of more than 9 weeks. And we do know that delay in treatment can actually lead to worse outcomes. So that's a real concern. So one of the things we need to consider is how can digital help with some of these referrals. We have to be realistic about the need for biopsies and for other hands-on treatments to happen or hands-on procedures, but we can also make better use of telemedicine. Antonella did mention the fear for patients going into cancer centres, and I'd like to just mention very briefly a personal story here. Very good friend of mine was diagnosed with Hodgkin lymphoma right in the middle of the pandemic. And frankly, I mean, she's a smart professional person, but frankly, she didn't want to go into hospital for treatment or for further assessment. And I was saying, you cannot delay. And in the end, actually, I said, okay, well, to prove to you that I trust that our cancer services are now beginning to work again, I will go with you to the hospital. So I actually went in and personally sat with my friend during the initial consultations and the planning for the chemotherapy. And it is rationally, I knew that they'd separated the cancer services away from the COVID wards in my local hospital, but it's a stressful experience for patients, and I can really understand that. I think the second element that we should think about as we consider how digitalization can be used appropriately, as well as artificial intelligence tools and apps, is what was the impact on patients with cancer who also contracted COVID-19? And it's fair to say that in most places there was a separation of cancer care from acute care as really on a rapid basis. There was a little bit of a delay in the UK with that, but I know that in many countries that they moved forward to trying to see cancer patients in physically separated locations. And so according to our discussions across the globe, the rates of COVID positivity have remained relatively low, possibly somewhere less than 10% in cancer patients. But the challenge is what happens when patients with cancer do contract COVID-19. The COVID-19 and Cancer Consortium is a group of US oncologists, and they have looked at nearly 1,000 patients across 100 different centers in the US who've contracted and had proven PCR test proven COVID-19. And really sadly that in the first 30 days, patients who were infected with SARS-CoV-2 had sadly had double the mortality rate in the first 30 days, rising from 6% to 13%. Advanced age, male gender, current or former smoker, and progressive disease were all particularly linked, sadly, to these early deaths. And another group, which has actually started in Italy by Professor Marina Garasino, a lung specialist, they've started a registry called TerraVault, and this is a global lung cancer registry. And one of the important findings, one of their early findings, is that chemotherapy use is in fact associated with an increased risk of death in patients who are infected with SARS-CoV-2. And there was a move towards treating more patients with immune checkpoint inhibitors and moving away from treating with chemotherapy. And an important part of this impact on cancer patients is the impact on trials. And as a company, we really went for aiming to stay open for business for trials and for no patient on a current trial to be left behind. We have had some delays in our trials, and that's inevitable. I think everybody's suffered from that. But we've really worked very hard to keep those trials going because, of course, innovative new treatments are so important for patients. And we have used some telemedicine in patient follow-up, and to be fair to both the FDA and the EMA, they've been very open-minded to us converting a number of face-to-face follow-ups to telemedicine follow-ups, and for those not to be considered protocol violations. So that moves to really the key discussion points of this whole conference, really, which is about how can we use digital to really overcome some of these issues with the pandemic, but also with the hope and the aim that those digital solutions will be enduring. And certainly ESMO has recommended that we move more towards digital, more towards telemedicine, and making that much more accessible for patients. And we do need to invest more in telehealth, both from industry side, but also from governmental side as well. But we do know that data is an issue, and GDPR is an issue, and we need to work together. FPIA initiated a health data mapping project in 2018, and then FPIA has just released a position paper on AI. These are tremendously helpful tools, but we also need to be careful how they're used. So, Ray, I'll stop there for questions.
Okay. Thank you, Mike. Can you hear me again?
Yes, we just lost you for a second, I think.
Yes, perfect. Thank you very much. I think we've covered a lot, which is fantastic. I'm going to pass on to the next panel, but Mike, I'm going to come back to you, and I'm going to ask you to give me a little bit more views on the challenges that you saw in regards to your last statement about getting data over EU borders. I think this is going to be a reoccurring theme in the discussion, and also what was the challenges research-wise in getting data, from the different member states, or was there any? Did it cause any slowdown in the research side of things? So I'll get back in just a bit. Please stay on the panel. If I can ask you to put your camera off, and ask Darine to put her camera on. And everyone in the audience, you probably noticed my colleague Vincenzo. He's ready to jump in should I drop off again. I'm calling from rural France. So sometimes it's a clear example of the need for more connectivity in Europe. Darren, can you put on your camera, please?
Do you see me?
There we are. Perfect. Thank you.
Yeah.
And you're coming in very clearly. Darren, as I understand, you're the head of personalized care and patient access at Roche, Global Medical Affairs. And with your team, you're working with stakeholders to make personal care a reality and looking at data and technology to be co-created to establish clinical meaningfulness and novelized, personalized healthcare solutions. What I want to ask you is I understand that you want to share some points in regards to clinical trials. And, how has this impacted? I find it quite fascinating. How can you continue to do clinical trials virtually in this crisis? What was your learnings? What was the benefits? How were you able to collaborate in that area? I'm going to pass the mic over to you.
Thanks so much, Ray, and good morning, everyone. So we have seen, I think COVID, and you heard it also from the panel, has impacted all areas of clinical care, including clinical trials. If we look to a recent report that McKinsey has published, more than 2,850 clinical trials in phase 2 or 3, with a majority of sites in partial or full lockdown. So it's really, COVID has been a huge impact for patients that are recruited in clinical trials. And this requires us really to mitigate the spread and impact of COVID, and companies such as Roche, but also other companies and researchers, we are looking into new ways to deliver clinical trials virtually. And we have, of course, an opportunity to really think around, it's not just about the virtualization of clinical trials, but ultimately how we bring trials to patients versus patients to trials, which has been, I would say, the mantra in the last years. And the word virtualization of clinical trials carry many meanings. Some call it decentralization, remote, site agnostic, direct to patients, etc. I think technology is being used at the point of care to be able to deliver testing, to support home visits, to be able to deliver drugs to patients, but also we have seen in the discussion also telemedicine and the importance of remote patient monitoring as types of technologies that can be applied across the trial journey. And of course, if we look into a virtual trial, we look into the process of setting clinical development and clinical trials, and from enrollment to consent to screening, testing, drug delivery, and monitoring. This is where we can look into the opportunities of digitalization. However, what we have seen in the last year, very few trials are considered fully virtual. And we do not have this one-size-fits-all model. If I look to Roche and what we have committed as an organization during COVID is similar to all the companies, patient safety is first, and making sure that we are supporting patients throughout the trials, but also supporting the investigators at the site. I would like to bring one example that we have done as part of our commitment to cancer care. We have a study that we are running on the safety and efficacy of molecular-based therapy for cancer of unknown primary. So CUP patients have an average life expectancy of 9 months, and they have limited treatment options. So stopping the CAPISCO trial like this could lead really to significant delays in delivering potentially life-saving treatments to people with cancer of unknown primary. So to minimize this disruption, what we have done is really during the pandemic, we are incorporating telemedicine into the CAPISCO trial, which we are conducting in partnership with Foundation Medicine. And we are also collaborating with the sites globally to ensure that the trial still is recruiting and continuing to assess outcomes. We also look to the services that we can deliver through the trial. So one of the services that we deliver through Foundation Medicine is the molecular tumor boards with patients, with physicians around the world. So being able really to connect the expertise that is needed to support in making the right decisions for patients. This is where we have to adjust our timelines for preparation of the molecular tumor board, develop more agile processes, and supporting physicians also in setting up technology in their homes where they were, and then enabling their participation in these tumor boards. So I think COVID is really highlighting an important area that we really need to serve the needs of patients and physicians beyond, the pandemic, and look into solutions where opportunities, specifically in cancer care, around softwares that support in molecular tumor boards, around digital patient monitoring to enable better symptom management and follow-up for patients. How can we really work together to really advance these types of innovation in clinical trials? And of course, one of the recent reports of WHO showed how much countries, that were surveyed were disrupted, in terms of the service that they are delivering in cancer care. And health systems are rapidly filling gaps through digitalization. We have seen also great partnership from the regulators, both on FDA and EMA, to really provide the guidelines to support in ensuring safety of patients, but also how we ultimately make sure that the data integrity and the data quality in the studies is preserved. And then, of course, this requires us to really think differently on what we can do together to enable this. And the pandemic has disrupted also the ability to do disease progression and monitor disease progression. And we are developing, for example, what we have done in Italy, setting up novel digital tools to help monitor patients in their illness at home, collaborating with local healthcare provider and patient advocacy group to monitor cancer patients remotely. We also were partnered, for example, in Romania with the Alliance of Chronic Patient Association and Uber to safely transport people to their doctors. You heard a lot of cancer patients were so scared to go back to the hospitals where, hospitals do not have the right measures to support patients such as cancer patients. So we needed to look into really innovative way of how can we support and preserve safety of patients. Another area that was mentioned is testing. And of course, you've seen the drop in testing, and that has a huge impact in the short and long term on patients' life in oncology. So one of the things we have done is, for example, in Italy, delivering FMI liquid biopsy testing in patients' home using validated at-home testing model and allowing patients to stay at home while tracking critical information for their disease. And this is really around personalization of care, or working like in Canada to support education around for physicians to support them on what other options they have for liquid biopsy for their community to help address patient concern about going to the hospital. So really an example of, in this journey of clinical development and clinical trials, innovative evidence generation, if this is through really building the ecosystem for high quality data and real world evidence, if this is through integration of digital technology across the patient journey from testing to monitoring to really treatment, it's an opportunity that we have as a community to really work together and collaborate together to make this real.
Excellent, thank you. Thank you. I wanted to just pick up on some points that you raised. Very interestingly enough, Julia on our chat box has asked a question about elderly patients. So there's so many great initiatives, and I'm sorry, I kept my camera off to improve the quality, but there's so many great initiatives you've talked about. I'd just like to hear, just in a few minutes, what are the challenges are you seeing? How would you get elderly patients up to speed to use, these digital tools? Is it working, or there's a lot more work needed? Do we need to get governments engaged?
I think it's an important question, and it goes back when we are designing solutions for patients. We have to do it together with the patient community and the patient organization to ensure that we are bringing first the insights and taking the lens of what patient needs are as we design the tools. It's not about coming with the shiny tool and then put it in the hands of patient and then it's not meeting their needs and it's adding burden to patients. So a lot of the design thinking that goes into the solution is really bringing first the patient perspective. And the elderly patient, of course, it's a population that is not digital native like the other types of generation of patients. However, as we are designing these solutions, the care team, the family are really critical support for the patients in enabling them to manage solutions. And this is something, an input and a feedback that is critical in the design of such solutions. And we need to ensure that we are not adding burden on patients, because if the solutions are not adopted ultimately by the patient community, this is not adding any value for improving care and improving outcomes for patients. So that's a lens that really needs to be taken, both not only from a policy perspective, but also from how we are co-creating these solutions together with the patient community and the patient organization, so they are really fit for purpose and addressing the needs and the burden that patients are facing. And you mentioned policies. I think part of what we are seeing in the COVID is really the diversity and volume of health data that is needed for an effective response requires us really to have a shift in mindset, moving away from just small number of large organizations controlling access to data to an ecosystem where data is shared to the broader patient benefit across their care continuum. And we welcome a focus on the creation of more data-driven ecosystem, because this will enable us to have more concrete and consistent tools for compliant access to data, ensure this data security, preserving patient rights and their privacy protected, and then adding value to the full ecosystem. And this is something that is really important for us in Roche, supporting this vision of the European strategy for data and enabling us to really work together to establish an ecosystem that is looking to empower Europe through the access to data and the creation of a health data space and improve ultimately health outcomes. So an opportunity that we have, but another area that I see critical in this innovation of study design is the benefit of ecosystem in the generation of high quality interoperable data that will contribute to quality real world evidence, because this is where you will also think in the study designs of having less patients that needs to be recruited, but really leveraging the real world data in a smart way and accelerating progress and innovation in R&D and enabling smarter research and development and acceptance of this by regulatory and access parties, and enabling ultimately that we are delivering also innovation faster to patients. So this is where I see really the opportunity from a policy perspective and collaboration perspective. Transcelerate, I think, is an example where we have seen nonprofit collaboration across 21 companies, including our organization, announcing the utilization of Datacelerate as a platform to share member company control on data from ongoing and planned COVID clinical studies, and as well from past studies. And this is, I think, it's a testimony for collaboration and partnership that are critical to enable advancement and innovation for treatments that are critical for patients.
And this platform This platform is operating in how many countries?
So it has been established by 21 of the largest companies, and the data will accumulate in the coming week and be available in different countries. I can follow up in terms of how many countries will be there. It's usually it's in the US, but will be globally available for COVID.
It sounds like you're going to be seeing a lot of the different opportunities and challenges, I think, in sharing that data, particularly in the EU, which we'll come back to and quickly address at the end of this first round with our member of the European Parliament, who's waiting very patiently. But thank you very much, Daheen. If I can ask you to turn your camera off, we'll get back to you in just a bit. And I'm now going to pass it to Bryce, who woke up extremely early in California to talk to us. Bryce, can you please turn on your camera?
Yeah, hold on a second. Starting it. How's that? Can you see me okay?
Yep, I see you turned on the side.
Okay. Yeah. Is that all right?
Okay.
I could if that doesn't come across well, I could flip the camera the other way. What would you like?
Maybe flip the camera if it's not too much problems.
No.
Get used to that. Perfect. Much better.
How's that? Is that better?
Much better.
Okay.
Yes.
All right. Cool.
Thank you very much, Bryce, for joining us. You're the global strategist for Intel's Health and Life Sciences group. Welcome.
Yeah.
Very exciting CV, as I've read. You're focusing on bringing technology and science together in the area of genomics and precision medicine. And you also have a rock band, I saw, which is very interesting. Maybe we can get to that, but more importantly, I think one thing that makes you quite individual in this panel is that you yourself was diagnosed with advanced cancer, as
Correct.
I understand, and trying to take your job now at Intel to address the cancer that you have, and then how can you help patients that also have your condition? Can you tell me about the diagnosis and what you are doing yourself and with your company and the greater community first? And then secondly, really want to hear about COVID. How does it affect a cancer patient such as yourself? And how do you deal with that?
Sure. Sounds good. So I got diagnosed with very aggressive metastatic prostate cancer about 6.5 years ago in 2014. And, just like any advanced cancer patient back in those days, I pretty much just went through what my doctor told me to do, which was the standard of care. It's a one-size-fits-all treatment paradigm where we all get pretty much the same treatments. Even though each one of us are unique and we're individuals, we still get a lot of the same treatments that everybody else would get. And that one-size-fits-all standard of care model, it helped me out for a little while, but it didn't get the job done. My cancer came back and it was really no match for the standard of care. And I started to lose hope. I didn't think I'd see my elementary school girl even get into middle school. And then I got just really lucky. As you mentioned, I work for Intel Corporation, and I started to learn quickly about genomics and the ability of these large cancer research centers and pharmaceutical companies to look at the biology of a tumor, to genomically sequence a tumor and then understand what's driving that disease at a molecular level, and then open up the door for cancer patients to get to something that would be more targeted and a better fit. And I started learning about all these companies that we were working with, and then I got frustrated because nobody was giving that to me. So I don't know if you can see this since I'm holding my phone now, but I have a T-shirt that says "Sequence Me." And I basically made this and I wore it into my doctor's office and I said, "Sequence me. I want to understand what's driving my disease." And they did. And that opened the door for me to get onto a drug trial that was a real good fit for me. It was a molecular match, if you will. And I was able to shut down my cancer for 2 years doing that. And now, kind of like if you're washing your hair, I just rinse and repeat. Every time I get a new lesion, I go and biopsy it, and then I understand what's driving it with my medical team. I use amazing solutions out in the marketplace, kind of like what Jean-Paul was talking about with OncoDNA in Europe. In the U.S., we have companies like Foundation Medicine, which Doreen was talking about, and places like Tempus that are large commercial diagnostic testing companies that will open doors for cancer patients and help them understand these new options and these new things that they can try. So, for me, it's obvious that genomics is going to be a key data set going forward that, people like me 5 years from now, everybody's going to be like me who has advanced cancer. I think you should get ready for a future in Europe where cancer patients are going to demand to know what's driving their disease and to demand to have new doors open for them beyond just the limited standard of care drugs that are available. And things like COVID have really given opportunities for innovation where we don't necessarily as a patient have to go into a medical center to get a invasive biopsy, a bone biopsy with a CT guided needle. We could just go get a liquid biopsy. We can have a mobile phlebotomist come to our house and gather our blood, and that can be used to find out what's driving your disease at a molecular level. Thanks for showing that. that's me in my house, right next to my garage, where in COVID times, I'm on a clinical trial right now, and it was a little bit of a dilemma for me, right? Because I'm one of these immunocompromised patients that we've been talking about today, and I had great fear in going into the medical establishments early on in March and April, largely because cancer might kill me in the long term, but COVID could kill me in the short term. So I basically called my clinical trial principal investigator and the drug company. I said, can you bring the trial to me? What can we do to use innovation to bring that trial to me? And again, this is a trial that, because of genomics, I found out, as my cancer was growing, what's the best fit for me as an individual. For me, that happened to be a clinical trial that was in San Diego, California. I kind of live back and forth between San Diego, I feel, even though my home's in Portland, right? Portland, Oregon. But for me to go to San Diego, I was afraid, to get on an airplane and to drive in an Uber and to stay in a hotel and things like that. So I asked, what could we do to bring the trial to me? And what we were able to do was, for labs, again, mobile phlebotomist. Are you able to hear me? I'm seeing notes that people are not able to hear me.
I hear you well. It's just okay. Melanie's computer, so just keep going.
Okay. All right. So, when I look at the components of my clinical trial, it was labs, imaging, clinic, and infusion, and then the other treatment that I had. So for labs, I just had that mobile phlebotomist come to my house and gather my labs. For imaging, I went to an outpatient imaging center, not affiliated with a, COVID ward, if you will, and that worked. For clinic, it's telehealth. I pretty much do telehealth all the time now. It's easy. It's a phone call, it's a Skype session, it's a Zoom session, it's a virtual, app that's connected to the electronic medical record. Doesn't matter. I pretty much do everything that way. The only thing I couldn't do was the infusion of an immunotherapy drug that I'm on right now. I had to go to the hospital for that. But for the oral drugs, and you're seeing a lot more switching now, and when it's possible to give a patient, instead of a cytotoxic chemotherapy, you can give them something oral, or immunotherapies that don't have the same damaging, impact to the immune system. Those drugs are now getting swapped in, and I had my oral drugs just shipped to my house. So I am going to the cancer centers again for my own clinical trial. To the point that was raised earlier, the protocols that they've adopted now at cancer centers here in the United States are really, really solid. I feel extremely safe. The amount of steps that they have put in to make sure that cancer patients are separated from COVID patients, and that the amount of distancing that's going on, and just the care that I get when I go, I feel like they've really stepped it up. But anyway, I just, before I stop here, I just want to emphasize that, I think in Europe, again, you're going to see more and more cancer patients demanding what drives their disease through molecular profiling, through genomic sequencing. And when you do that, you start finding out where the patients are. They may not necessarily be located near a cancer center. They may be remote. They may be in rural areas. And I think COVID in some ways has been a blessing in disguise, because with COVID, you're not going to enable your patients to always get to the cancer center to get to trial. So I think in a genomics guided world where patients are going to be, slotted into the right type of treatment for the right time, the right patient, the right time, the right intervention, that's going to be based on a molecular driver, not necessarily the tumor of origin where the cancer started from. Those patients are going to be all over the place. So if you want to reach them and get your drugs to them, you're going to have to figure out ways and innovative ways to bring your drugs to those patients. And if more and more people get sequenced, then that opens up the door to drug companies to get their drug to many, many more people, because in the future, it's not just going to be, a prostate cancer patient who has advanced prostate cancer getting docetaxel, some old ancient chemotherapy, right? It's going to be, what is driving your disease? What targeted drug are you going to get? What combination of maybe immunotherapy and targeted drug are you going to get? and how can we get that to you in a way that doesn't require you to have to go into a cancer center every time. So let me just stop there.
Thank you, Bryce. Your talk is driving a lot of questions, and I think some questions that appear in the chat box, and some questions that I would like to ask, probably to our member of the European Parliament who's coming up, but more to Antonella when I get back to her, as to is this what you're experiencing, what you said you're experiencing in the U.S., is that generally something that we do not have here in Europe? Or is it a mismatch? In my home country of France, maybe they're doing a great job, but maybe in other countries they're not, and try to get a mapping of that would be interesting. I don't know if you know the answer to that, Bryce. But I
don't know the answer to that, but I do know there is some innovation that's taking off here that may not be there. I mean, I'll just give you one example real quick. So we have a project at Intel that's, when you think about social distancing, about the ability to enable, a cancer patient to not have to go into the hospital because you don't want that cancer patient to get exposed to COVID because they're more likely to have a severe case. Well, what about the caregivers that are risking their lives every day? The ICU teams, the ICU nurses, the intensivists, the anesthesiologists, the ones who are on the front lines. What can we do with technology to enable them to get everything they need outside of the ICU room into some other place where they could take care of it? And, we've done that. We've got it was funny. We were talking to doctors in New York City. That was the first major, that was like Italy, right? New York City in the United States got hit the hardest at first. And we started talking to critical care teams. And we said, what do you need? They said two things. Get all of the data that's inside the ICU outside of the ICU. We don't want to have to go into the patient room 17 times a shift because that opens us up for more exposure. Can you get all that bedside data outside of the room? And then can you scale and can you clone our ICU nurses? Do you have technology that can clone an ICU nurse? Because we're getting hit and we're getting sick and we don't have the staff to take on the flood of patients that are coming in. And actually, we did have a solution for them. There was a small startup that we worked with called Medical Informatics in the United States. And what they do is they collect all that bedside data, even ventilator data and heart monitor data, all of it. And they enable virtual rounding and virtual ICUs. So you can take vendor agnostic devices that are in the ICU room, take all that rich waveform data, move it outside of the ICU into a doctor's home if you want, or through Zoom sessions where they can do virtual rounding. And you can have a doctor who's in quarantine actually remotely monitoring patients and keeping them well. And then getting all that retrospective data that now you can do analytics on and create COVID risk scores. And there's some just exciting stuff that's going on.
Well, Bryce, that does sound exciting, but it sounds very depressing that in this day and age, we still don't have systems to carry data a few meters away. It is quite shocking that this is still the case. I wanted to ask you this question from Marta. How much of this treatment is covered by health insurance?
Yeah, it's a great question. So, I mean, when you look at even like genomics from a diagnostics perspective, in the United States, we have a lot of, employer-driven healthcare. You have to get private insurance from the marketplace. And today, fortunately, if you are an advanced cancer patient, you can get that type of molecular diagnostics. You can get genomic sequencing for your cancer. However, what's interesting is when you get that genomic sequencing test and they come back and they tell you what's driving your disease, that opens the door to more expensive precision medicine drugs that, a lot of times will be an off-label option for you, right? So for example, let's say you have prostate cancer like I have, but there is a drug for BRCA mutant breast cancer patients called olaparib. It's a PARP inhibitor that got approved for breast cancer. But what if I have a BRCA mutation? That is considered an off-label drug where I have the same molecular background as this breast cancer patient. This drug's probably a good fit for me, but insurance may not pick it up, right? They may balk or they may reject it because it's considered off-label. But that's why we go into clinical trials. And it's a tragedy today that only 4%, 5% of cancer patients in the United States go on to trials. This should be 40%, because clinical trials are where all the interesting new drugs are being tested that actually will probably work better. And those insurance companies don't really get involved in too much because you're, as a patient, volunteering for research. So, you know, that's kind of the way I look at it. Sometimes some of these off-label expensive drugs are hard to get, but you can enter into a trial. And then in terms of COVID, like for me, mobile phlebotomy, yeah, I had to pay for that. My insurance didn't cover having a phlebotomist come to my house. But telehealth, no. I mean, that's easy. Like in the United States, they've really relaxed the restrictions and regulations on telehealth. I don't know anybody that doesn't do telehealth today. Every one of my advanced cancer patient friends in the United States, we all do virtual visits with our doctors now, and it's all reimbursable. So I don't know. I hope that helps a little bit.
It does. Yeah, it does a lot, Bryce. It's a lot of food for thought. And I think in some areas, Europe has a lot to catch up in. And on that point, if I may ask you to turn your camera off.
Sure.
And thank you for holding your mobile phone. Sorry for the inconvenience.
Yeah, no problem.
And I'm now going to move to Susanna Solis, member of the European Parliament. Susanna, can I ask you to turn your camera on, please?
Hello, Ray.
Hello.
Can you hear me?
We can hear you very clearly. We can't see you yet.
Yes, thank you. And first, I would like to thank all.
Susanna.
My camera?
Yeah. Okay. There you go. Yeah, your camera is on. Okay. Fantastic.
Okay.
So thank you very much, Susanna, for joining us and being very patient. I know that some of the other panelists need to jump at 12 sharp. So let's get some 10 minutes from you. You've heard a lot from this panel. You've heard a lot of areas where Europe can improve. We have the Europe Beating Cancer Initiative coming up. So maybe we can get a lot of digital tools to be adopted and a lot of these great things to make Europe maybe a leader globally. How about that? And if I could just introduce you, you're part of the Renew Europe party, and you're from Spain. And you're also a member of MEPs Against Cancer. And you are part of several committees. So those of you in the audience that don't know how the European Parliament works, there's many committees focusing on different things. You're on the Environment Committee and the Industry and Research Committee, as well as the Special Committee for AI. So let me pass it to you, and let's hear your response on what was discussed here and your thoughts. Thank you, Susanna. Over to you.
Thank you, Ray. I could like to thank all the speakers for the inspirational contributions. It is amazing to see how digital technology is transforming the way healthcare is delivered. And as we have seen today, the pandemic has accelerated the digital transformation of the healthcare system, and we certainly need to take stock of the lessons learned for the future. Speeding up the pace of digitalization can deliver significant benefits to patients and populations. It can improve the productivity and efficiency of care of delivery. It can also improve the day-to-day life of healthcare practitioners because they can spend more time with patients, and it can even get life-saving treatments to market faster. And at the same time, questions have been raised about the impact some solutions such as artificial intelligence could have on patients, on practitioners, and on health systems, and about the potential risks. And there are ethical debates around how AI and data should be used. There are many debates on the Parliament. All in all, the COVID-19 crisis has been a great challenge that forces us to review our priorities and to ask ourselves which is the best way to confront the immediate future. And this is the debate we have now in the European Parliament. We need to take away some key lessons from the crisis to make this European project stronger. First, we need to strengthen cooperation between member states. Second, the importance of having resilient healthcare systems. Third, the need to have a competitive industrial and technological capacity in Europe. And fourth, the crucial role of research and innovation, technology and digital tools, and how public-private partnerships are essential to find new solutions. And as we have seen with your testimonies today, the crisis has made us realize the need to speed up the digital transformation of our healthcare system. We mentioned today many challenges. We have many challenges ahead. The need to accelerate the common health data space, the lack of data interoperability across the different European, national, or even regional systems. We need a common set of standards that enables the integration of all these technologies, and a robust legal framework that ensures the trustworthy and ethical use of data. And of course, you mentioned also the need to educate the healthcare professionals on emerging technologies. And I have to say, there is no time to waste. It is time for Europe to act, and we need to act now. And this is my main message. Remove these barriers is a priority for the European Recovery Plan. And if we want a resilient, a digital, and a sustainable Europe in the future, it is now time for action. My second message is that fight against cancer was a priority before COVID-19 and still remains a priority now. The 4 million people affected in Europe need the European strategy to fight cancer more than ever. And I am glad to see that there is no change in the Commission program, and the presentation of the Beating Cancer Plan will take place at the end of the year as originally planned. Our commitment from the European Parliament is to make sure that enough resources for this are allocated in the Recovery Plan, in the MFF budget, and in the framework program Horizon Europe, where, as you know, we are defending an increase of the budget to reach 120 billion to guarantee the necessary level of funding that all those projects that you mentioned before need. But it is not only about budget. We have seen today that prevention, early diagnosis, and personalization of treatment have never been more tangible than now, with the help of key enabling technologies like artificial intelligence, genomics, or the potential of digital data. And last week, the European Parliament approved 2 special committees whose work will be crucial in the fight against cancer. One is the Special Committee on Beating Cancer, and the other one is the Special Committee on Artificial Intelligence. Both are temporary committees to identify priorities and focus on concrete actions and not on vague proposals. For example, the Committee on Cancer has the role to understand the differences and reduce the inequalities between member states and within member states. Improve, for example, the affordability and accessibility to cancer medicine, and to evaluate legislative change to incentivize innovation and breakthrough treatments like those ones especially for children or rare cancers. And of course, we need to address in this committee the development of common standards to allow the interoperability of healthcare systems on also cancer registers. And making reference to what was also mentioned before, through this committee, we will also evaluate the implementation of the Cross-Border Healthcare Directive and analyze also the functioning of the European reference networks in order to ensure the best treatment and advice are available for cancer patients. On the other hand, the Special Committee on Artificial Intelligence will study the impact and challenges of rolling out AI and propose a roadmap with objectives and steps that need to be taken to achieve them. I don't need to emphasize the transversal and transforming capacity of AI in the healthcare sectors. You have already mentioned it contributes to the search for new pharmaceuticals, the design of better clinical trials, implementing personalized medicine strategies, helps improve the diagnosis. But we should also ensure the development of a trustworthy, ethical, and technically robust AI based on our fundamental values and fundamental rights. And of course, it needs to be done in a way that does not stifle innovation, but rather promotes it. And I see a clear link between those 2 committees to make sure that the EU leads the way in the application of new technologies to all stages of cancer. And finally, innovation, innovation, innovation. The crisis has highlighted the importance of scientific knowledge and the need for technological development to respond to the challenges posed by diseases. We talk about artificial intelligence, about data, of course, the development of high computing capacity, security, and adequate networks, and training and digital skills. Technology is not possible without the people who are capable of designing and developing it. And if we want to make sure healthcare professionals use these new technologies and maximize their potential, they have to understand and trust them, and we need to provide them with continuous learning. Thank you. And that goes my overview from the European Parliament.
Susanna.
I heard so many interesting reflections today that it was really, really valuable for
Thank you.
Thank you.
Thank you, Susanna. Can you still hear me?
Yes.
Good, perfect. Thank you. I've taken down 6 big areas that you're going to try and achieve in these committees. And I really want to thank you for coming to speak to us, because I also know there's another challenge, and that is for people who haven't had digital as a priority, as a policymaker, all of a sudden realize we need to make it a priority and then understand all the issues. So your leadership there as well with your fellow colleagues in the European Parliament is going to be crucial, along with, the other young MEPs that are around who have been pushing the digital agenda. So please continue that and let us know where we can help, of course. I want to see if you can hold on for as long as you can. I know you have to probably run back to the Parliament and you have a very busy agenda. If you do have to drop, I understand. If you can stay on, that's great. So I'm going to now direct questions to the other panelists. I have been told by the organizers that we are a little bit delayed in regards to our final speaker from the Croatian government. So I do know that, Antonella, you have to leave now, I guess. I don't know if you have any time for a final question.
Yes, I do have it here.
Okay, so if you have to jump, understand, please do so. Just, you've heard a lot on this call. You know about the challenges. You've seen what Bryce is talking about in the U.S. What can you say to us, to this whole audience, to the Commission, to the European Parliament, to industry, that we should be listening to?
Well, it's coming out very clearly that we all need to work together in order to build up on trust between all the different stakeholders, because patients need to trust digital health more, and in order to trust digital health more, we need to know more and be empowered on the usability of digital health. So that is very important. So I really appreciate this panel. I mean, it's amazing how you managed to put together all the different stakeholders on this hot topic at the moment. So I hope that we will continue the discussion and we will not stop here. Then it's coming out very clearly that digital health solutions need to be prioritized, both on the cancer plan, but also in terms of research, so in the cancer mission. And to this extent, I must say that we have a lot to learn from the US still. And in Europe, there are huge disparities in between countries and within the same country as well, between regions. And it would be good to be able, maybe through the cancer plan, map the situation in Europe as far as digital health use and implementation, but also it would be ideal if within the cancer plan we can also facilitate the share of best practices, so to fill the gaps in between countries. Now, I don't know if the MEP, Susana Solis Perez, is still there, but it would be good. I mean, I would like to invite her to join the parliamentary intergroup Challenge Cancer, which is going to be launched on the 1st of July. I mean, she should really join this group because we really needed to put all the dots together. So thank you.
Thank you. I will be there. Thank you.
Okay. Excellent. Excellent. Antonella, there was one question from the audience in regards to elderly patients. What can we do to help them? They're going to be excluded, require skills, need special focus and attention. What are your thoughts on that?
Yeah, well, that is, as I said in my statement, I mean, telemedicine and digital health is one of the best solutions, but there are groups of patients which may be left out. And you know, we needed to consider the so-called digital divide. So that is a challenge. So with the elderly people, they needed to be supported in some way in the usability of digital health. I can say that by experience, in Italy, for instance, now with the COVID-19, I don't know if you heard that the outbreak was tremendous in nursery homes for elderly people. And the one way to facilitate their contact with their families was through a tablet. So some basic digital health literacy is fundamental and might be essential for some basic tools. Of course, for other more sophisticated tools, they need support. And I must say that normally elderly people have some formal or informal support by younger people, so that within the family or outside of the family, so that kind of help can facilitate their accessibility to digital health. But it is a field that we needed to explore more.
Thank you very much, Antonella. Again, I would love to go on and ask you more questions, but I know you have to leave. You have another panel. So thank you. Yeah. If I can now get Mike, if you're still there, to join us.
Yeah, I'm still here.
Thank you, Mike.
Do you want me to turn the camera on or just?
As you wish. I'm keeping my camera off just to improve quality.
Okay. No, that's fine.
You decide.
No.
I did have that question that I want to bring back to you in regards to, you know, the challenges of getting data across borders. I also have seen a question that was raised by an audience. I generally think it's being raised for all companies on here about the safety profile of drugs and for example, having insightful data could provide companies with new safety information unknown at the time of the launch. If you could talk about that in regards to your response.
I mean, I think that telemedicine offers an opportunity for us to actually better understand the safety profile of our drugs. And of course, we conduct our large-scale phase 3 trials with registrational intent, but it doesn't stop there. And when our drugs are on the market, we're anxious to learn more about the safety profile. So let me give you an example of how use of digital can actually help us learn more about safety. So, and this can be done through patient app. And we've been working with a group in Canada from University of Montreal on this as a possibility. It's still in development, but we're discussing this now. And the idea of this is that the patient has an app on their phone and they can report any kind of adverse experience in real time through the app. And it can be free text, so we're not making it complicated for the patient. And of course, that can then be analysed very quickly by the oncologist and reported as a safety report to the authorities as needed. But it allows you to aggregate and build up a huge amount of both safety and experience data from patients in a very convenient way, because challenges for a patient who comes to a clinic, they may not remember how they felt exactly 2 weeks ago, but if they can put it in real time, then I think we can learn a lot more about the experience of our patients on our drugs. So I'm pretty enthusiastic about that.
And will we be seeing the adoption of such real-time analytics, in your opinion, quickly? Or are there some challenges to?
Well, there are I mean, obviously GDPR comes into play again, and we have to work around that, and so that is a challenge. There's also the challenge of making sure that any safety signals that are picked up are reported, because we're under quite appropriately under strict timelines there. So everyone has to be kind of on point and trained. And the third issue is that not all patients can use apps. Or are able to use the technology. And in fact, some of our most vulnerable patients may be the ones who are least able to enter this type of information into apps. So we have to engage caregivers in this process as well, because we want to avoid bias. We don't want the patients who have the most health issues to be the least likely to be able to report in real time. And that's something we're thinking about. Then, of course, if you share with caregivers, that brings another layer of GDPR. So there are lots of issues to solve. And the final issue, just very quickly, I know we're out of time more or less, is of course security. We have to. We've seen so many big companies and so many big organizations with data breaches, and these types of data are super sensitive for patients and caregivers, and we have to be extremely careful about encryption and safety of databases, that they can't be hacked by unscrupulous individuals. And that's something we're working with the group in Canada on, some really extra layers of security.
Mike, thank you very much. We do have the final speaker on board, but I want to give you, a minute to do you have any closing remarks or anything you want to say to the audience?
So from my perspective, I think we need to make use of this crisis to bring good. And we're very committed, I believe, not just MSD as a company, but as an industry, we're very committed to telemedicine, to the use of AI in trials, and to flexible ways of delivering care, which really put the patient at the center. And we should certainly make use of this terrible situation to drive that forward. And of course, we do need to be prepared for a second wave. And I really liked what Bryce said about protecting caregivers as well, because a sad reflection is that one of the first healthcare professionals to die in the UK was an ENT surgeon who contracted COVID during examining patients with head and neck cancer. So we also need to remember the healthcare providers as well.
Indeed. Thank you, Mike, again. Darren, I'd like to pass it to you. I know we have our final speaker. Please be patient, but I would like to give our panelists just a few more minutes to make some closing remarks. And Bryce, you're next. Darren, what can you like to say in a couple of minutes in regards to the challenges and key messages?
I think the key message that I have is, as industry, as the whole community needs to work together to respond to the COVID needs, but also beyond COVID, how we are setting the new norm for innovation in clinical development and clinical care. And this is really an opportunity for us to really bring health equity and bring innovation to patients, accelerating the use of data technology and really upgrading our healthcare systems, working closely on education and on integration of solutions that will help us deliver better care and cancer and better outcomes for cancer patients. So really looking forward, I think we cannot do it alone. The collaboration and the trust would be really at the core of successful implementation in Europe.
Thank you, Dan. And Bryce, you have the final word. Please, over to you.
Okay. Well, so I think that if you were to look, across the United States, if you were to look across Europe at every cancer patient who has gotten COVID, and you were able to mine that data, the amount of insights that you would be able to find that would be super helpful for dealing with this going forward would just be remarkable. And, I just kind of go back to something that I've seen a lot over here, and that's that when data is not liquid, when it's not freed up and when it's not unleashed, innovation doesn't happen. entrepreneurs, they go to industries where data can be freed up. And, I just want, you folks over there in Europe as well, it's everywhere, every country that you're in, that you're working across, to do what you can to share, because the more that you share, the more you actually have. The IP isn't in the data. The IP is going to be in the insights that you get when you create an algorithm, for example, that looks at much more data than you currently have. And I just want you all to know that technology is out there that can enable you to securely share data, to securely access data that you don't have, to analyze data across hospitals and their data sets, and even train your AI models, regardless of where data is, right? It doesn't have to be centralized. It's centralized. Like we at Intel are working on a lot of projects where we're able to, do distributed learning and multi-party analytics and do it in a secure way, to Mike's point, that we can encrypt data at rest, in motion, and in runtime. So that is, the technology is there. You just have to dream as big as you can, and then look for solution providers that can help you secure this stuff and enable that type of multi-party analytics on a lot of this data that you may not have yourself.
Excellent. Thank you very much, Bryce, and to all the panelists. I'm going to pass it back now to Antonia, and I see there are some questions in the chat box we didn't get to, but I will do my best to get to the panelists and see if we can find some answers for you. Antonia, back to you.
Thank you so much, Ray, and thank you once again, Antonella, Bryce, Mike, Susanna, and Darin. This is very, very interesting. Thank you so much for joining us today. And with this, we have arrived to the final part of today's conference. Conclusion will be given by Nikolina Brnjac, State Secretary, Croatian Ministry of Foreign and European Affairs. So good to see you, Mrs. Brnjac. Hello.
Hello. So good to see all of you.
Yes, and these are your 10 minutes, so take it away.
Okay, thank you. So, ladies and gentlemen, allow me to say a few words today on the behalf of the Croatian presidency of the Council. In many ways, you will agree that this will be a memorable presidency, not only for my government, but for all of us. For Croatia, it is the first time in its history to preside over the Council of the European Union. More importantly, our presidencies had taken place in circumstances that no presidency of the Council experienced ever before. Looking back on a completely different world that we lived in only 6 months ago, our motto, strong world in a world full of challenges, sounds almost prophetic. We based our program on 4 distinctive pillars: Europe that develops, Europe that connects, Europe that protects, and influential Europe. With these priorities in mind, we started our work on complex and important issues for the future of Europe, from Brexit to multi-annual financial framework, from Western Balkans and enlargement to managing migration and fighting climate change. However, the outbreak of the COVID-19 pandemic made us significantly adapt our work in organizational, logistical, and substantial ways. Looking back over our 6 months, we can say with complete certainty that no presidency in the history of the EU has ever been so health-oriented or based its work as much on digital solutions without any previous planning for either of them. As you know, during months of almost complete lockdown in all of Europe, we had to come up with innovative solutions to ensure that our work within the Council continues. Let me share with you a few words on that work before I proceed to the subject that you were dealing with as the Virtual Policy Summit. The Commission adopted more than 300 decisions and other acts since the beginning of the crisis. Most of these were neither planned nor featured in the Commission work program for 2020. That means that healthy issues during Croatian presidency have become a focal point of the EU politics and shifted our presidency priorities. Since March, we have focused all our efforts on the EU response to the crisis and preparing for recovery. I believe we managed to do that very successfully. I'm proud that together with the European Parliament, we came to a quick agreement on the Commission's 2 key legislative packages designed to mitigate the impact of COVID-19 on the whole EU level. From 13th March until today, we organized more than 650 meetings. In total, more than 60 were informal meetings and high-level video and teleconferences covering different policy areas and sets of measures taken in nearly all sectors of life. European health ministers have been meeting regularly from the 13th February and discussing all COVID-related issues in continuity. The ministers discussed measures and activities undertaken by way of response, as well as how to strengthen member states' cooperation in the area of public health. All debates echoed the importance for further raise of the collective and individual awareness about the threat posed by the COVID-19, need to strengthen the protection of people at risk and the elderly, and need to establish coherent containment measures, including evidence-based advice concerning travel to and from risk areas. The need for monitoring at the European level of the availability of medical equipment and medicines in the European Union with the aim of securing the production, stocking, availability, and rational use of protective equipment in the Union was also highlighted. At the meeting on the 10th of June, the ministers exchanged views on the legislative proposals put forward by the European Commission for a new EU health program, EU for Health. The EU for Health program is a standalone program with a significant budget, expected to be about 25 times higher than the current health program. The new EU for Health program is broadly welcomed, and I would like to highlight some particularly important priorities of the program. Long-term strengthening of health systems through ensuring better sharing of data on cross-border health threats. Further digitalization and interoperability of health systems with less dependency on the supply chains from the third countries. Strengthening the role and functioning of the EU agencies such as the European Centre for Disease Prevention and Control and the European Medicines Agency. Today, you discussed the post-COVID-19 Europe digital health future and responses needed to achieve better health for European citizens. Over the last few years, digital technologies have transformed our economies and societies, affecting all sectors and deeply influencing daily lives of Europeans. Data is at the center of this transformation. I want to underline an important message here. Citizens will trust and embrace data-driven innovations only if they are confident that any personal data sharing in the European Union will be subject to strict data protection rules. The European Union must guarantee that protection to its citizens. The COVID-19 pandemic is one of the most serious tests in the history of the European Union. Even though the disease did not have the same impact on all member states, it represented an overwhelming burden for many of our health systems. Thanks to our collective efforts, the spread of the virus has slowed down across Europe and the number of new infections is decreasing. However, new outbreaks and individual cases recorded in the last days prove that we have to remain vigilant. I believe that your discussion at this conference, along with your conclusion, can contribute to better addressing the epidemiological situation in the whole European Union. I have here with me a short summary of the conclusion prepared by the Digital Europe. This is very important as we need to hear the ideas of industry and entrepreneurs in order to better shape public policies to benefit our economy and our citizens. Before we finish, I would like to thank the organizers, the Croatian Chamber of Economy, and our host, Mr. Burilovic, and all of you for your warm welcome and all of your contributions. Finally, even they are not here with us today, allow me to wish a lot of success to our German colleagues, who will, along with Croatian presidency, be the first ones to lead the work of the Council in post-COVID crisis. Thank you very much.
Thank you very much, Mrs. Bennett. Hopefully, Germany will have a little less difficulties in comparison to Croatia in terms of COVID and global pandemics and et cetera, et cetera. So we can only wish them good luck. Thank you very much once again. This was Nikolina Brnjac, State Secretary, Foreign Ministry of Foreign and European Affairs, Croatia. That's it. As I said earlier, we have come to the end of the summit. You will receive an email, all of you will receive an email in a short 2-minute survey. It really only takes 2 minutes, so please fill it out. Please do so, as we're continually learning how to improve doing online conferences. So take those 2 minutes, please. Once again, on behalf of the organizers, I would like to thank all of our participants and all of you watching us from your homes or offices. For the future, we can only hope that the quality of modern healthcare solutions will be on the rise, while number of those in need will be in decline, of course. Good luck to all of you. Have a great day. A lot of greetings and great wishes from Zagreb. Take care. See you soon. Bye.
Thank you.
Zaustavi video, jer ćete ubiti. Ok.